So few videos on that. Good afternoon, everyone. Today we have joined together to conduct this national webinar on bridging the gaps in organ transplantation. We have with us Dr. Anil Kumar, Director of NOTO, who will be addressing you with welcome address. Good afternoon. Are we audible clearly to everyone? Can anyone confirm?
Yes,
Are
sir.
we audible?
Yes, sir. Yes, sir.
Okay. Thank
Yes.
you. Uh, so, welcome to this national webinar on bridging the gaps in organ transplantation, transcending the barriers and transforming lives. As you all are aware, that there is a huge gap exists between patients who require organ transplants and the organ donors that are available in the country. And to strengthen the healthcare systems, facilitating organ donation and transplantation, it is one of the top priorities of the government of India. So today, this webinar is also an attempt to educate uh, all the people, all the stakeholders who are involved in organ donation and transplantation, as well as the members of the public in the not only in the organ donation but also in the area of prevention of diseases which cause organ failure. So, welcome to this webinar. First of all, I would like to welcome our respected DGHS ma'am, Dr. Sunita Sharma, Director General of Health Services, Ministry of Health and Family Welfare, Government of India, who is the chief guest for this uh, inauguration of this webinar. So I'll be welcome, ma'am, and for taking out time and giving your words of wisdom and regarding this webinar. So also I welcome all the speakers. We have the very eminent and renowned speakers from all over the country. Like they are from different parts of the country. We have Dr. Sandeep Mahajan, who is the who is from the Department of Nephrology, AIMS Delhi. We have Dr. Sandeep Seth, who is from Department of Cardiology, AIMS Delhi. Dr. Akash Shukla, who is Director of the Regional Organ and Tissue Transplant Organization, and also he is the renowned gastroenterologist, not only in KEM, but he also works in HN Reliance Foundation. Then we have Dr. Rahul Pandit, who is a renowned and eminent expert on the brainstem death subject and organ donation, and he's chairman of the critical care of the HN Reliance Foundation Hospital. Then we have with us Dr. Dipesh B. Kanwar, who is the uh, who is the one of the pioneer surgeons in the PGIMER Institute, which is there in Chandigarh. So there they are the one of the institutes which are doing donation after circulatory death, which has a potential to improve the organ donation, the pool of organ donation in the country. Then we have with us Dr. Vivek Kute, who is a who doesn't know Dr. Vivek Kute. He is not only known in India, but he is very well internationally known figure and internationally known nephrologist. And he has demonstrated that how the swab transplantation can increase the number of transplantation in the country and improve the outcomes of transplantation. And he will be like he's from IKDRC Ahmedabad, and he'll be talking about the One Nation One Swab Transplant program. So I'm assisted by my all the colleagues from the NOTO. We have Dr. Sana Ahuja, Dr. Kanika Rastogi. Then we have our
So your voice is not coming anymore.
passed in 2000. The act was passed in 1995. So that time, this when the act was passed in July, so that month is now being organized as an organ donation month. So as an initiative under this organ donation month, in the current campaign which we are calling the Jeevan Angdan Jeevan Sanjeevani Abhiyan, and that is the life saving potential of the organ donation. So this will be we will be celebrating this 15th Indian Organ Donation Day this year. The day is on third, but the actual event that we are going to organize will be is being finalized in consultation with the dignitaries. So this campaign that we are organizing this year, it has certain objectives, basically to increase awareness about organ system death and diseased organ donation, and also prevention and control of illegal practices which are there, to bust myths and misconceptions regarding the organ donation, and to basically to augment identification of the brainstem death patients and by the hospitals and increasing donation. So I can see Dr. Vasanti Ramesh also in the audience. She is the former director and the founder director also of the NOTO. She is welcome, ma'am, Dr. Vasanti Ramesh. And so all of you are, uh, uh, will be enjoying the learning sessions which are being held today. So now I would request our DTHS ma'am, uh, Professor Dr. Sunita Sharma, to address all of you and to with her words of wisdom and blessings. Yes, ma'am. Thank you.
First of all, a very good afternoon to all of you. It's been a great pleasure to join this webinar, which is titled Bridging the Gaps in Organ Transplantation, Transcending Barriers, Transforming Lives. This is actually the month of July is a part of the national campaign, and has already Angdan Jeevan Sanjeevani Abhiyan. I think सबने रामायण पढ़ी है तो we will think of Sanjeevani. That Sanjeevani is the jari buti which is supposed to give life. So this is similarly this organ donation is like giving life to others. So it is organ donation is not just a clarity of treatment, but it's an act of compassion. And in our society, in our community, there are very still the gaps are there. So we have to fill those gaps. We have to rise above the obstacles before the barriers which are there. Then we can transform lives of others. Now, as we know, there is always a difference between the demand and the supply. Demand is more and supply is less. So we can do two measures. Either we can reduce our demand or we can increase our supply. So reduce the demand itself is already told that we have to work on prevention. So most of the lectures today, I think, are those how to prevent damage to our organs. We should have healthy organs. So the lifestyle, you must have heard recently, most of the celebrities you are seeing, they die, they are being certain cardiac arrest. Recently also one of the death occurs. Possibly there is some products. So we have to be very careful organs to be damaged by these different types of drugs which are there in the market. We have to pay attention. So you will be enriched by the experience of various from talking on the organ. The second aspect is increase the supply. So we have to motivate, we have to convince the society and the different IC media or different ways to motivate them. And the most critical part is, I think, is the identifying brainstem. But this is a very crucial thing, and it's a very sensitive issue also, because somewhere in the heart of relatives, it remains there may be possibility the patient might come back. So that has to be accepted. Which I think there's a talk on this how to diagnose the brainstem. I know it is very difficult decision to be taken by the relatives. When body donation is have done a body donation to my mother-in-law, and it's very tough decision to take. So brain is still death is still it's more tougher decision I think take, but we have to understand this. So I think this webinar is a very good platform where all the experts of the various parts of the country are talking on this transcending key barriers.
हाँ जाएगी दीदी जाएगी मैं चालू करूँ ना तो मैं देखो बदल प्रॉब्लम नहीं दिखा
You can make it right to others. For today's event. So let's begin our journey. Today, to open, we have Dr. Sandeep Mahajan with us, speaking on the topic of prevention of kidney diseases. He is professor of nephrology at NIMS New Delhi and a leading figure in kidney disease research, education, and policy in India. Sir is the education ambassador of the International Society of Nephrology, deputy chair South Asian Regional Board of the International Society of Nephrology, and he's also the secretary of the Peritoneal Dialysis Society of India. His role in shaping India's dialysis and transplant programs underlines his impact as both a physician and a policy advisor. Sir, we hand over the mic to you. You may present now.
Okay, so you would be sharing the slides or I would share it?
Dr. Sandeep Mahajan. So Dr. Sandeep Mahajan, kindly you can start your presentation. Do you want us to share your presentation or you will share it from there?
I think so. Just see if
So we can't hear you.
Okay, you can start sharing the slides. Just hold on if I can open it. Just give me a minute, sir. So are my slides visible now?
Share. We will do it himself. Sharing
Yes, sir. Yeah, are my slides visible now?
Yes, sir. Yes, sir.
Sir
Okay.
की आवाज नहीं आ रही.
My mic is on.
नहीं आ रही.
Am I audible or no?
यहाँ आवाज को नहीं आ रही sir.
Yes, sir. We can hear you.
Okay, thank you. So, thank you very much, ma'am, and thank you for this opportunity to be here. So, I would be talking about a vital organ which is not very commonly discussed. The kidneys does amazing work. It does so much for the body, and still very few people in the general public are really aware about the function, the role of the kidney. And it's the knowledge of knowing the functions of the kidney which forms the basis of prevention for kidney diseases. So first and foremost, we have to actually tell people what vital work the kidney plays, and then only people would be more aware about the kidney diseases and how to prevent them. So the kidney obviously is vital in the sense it would have around 20% of the cardiac output, and we all know that it clears the blood of all the uremic toxins, of all the toxins which are found in day-to-day activity of the body. But it is also very important to maintain the blood pressure, to maintain bone health, to build up the hemoglobin of the body. And therefore, if the kidney fails, you would have involvement of multiple organs. The hemoglobin, the bone involvement, they all would occur directly. And then you would have progressive accumulation of the toxins and the acid in the body. So, what do we mean if we say that you have kidney failure or you have chronic kidney disease? It basically means that there is a sustained and irreversible loss of kidney mass and function. And this is the time when we say that the kidneys have started failing or they have failed completely. It is divided into various stages, starting from high risk to early stages of kidney damage, in which there is only mild decrease in GFR, to a progressive decline in GFR, to the tune that in the end they would be requiring dialysis or transplant. Once we talk about prevention, we have to know whether the kidney disease is a common problem or not. Chronic kidney disease currently is a global health issue of the 21st century. Much of the focus, unfortunately, has been on the patients who have end stage renal failure or those who require dialysis and transplant. It is important to realize that nearly 50 times the patients who are on dialysis would be the number of patients who are suffering from early stages of chronic kidney disease would be 50 times more than the patients who are suffering from end stage renal disease. The prevalence of chronic kidney disease in various populations is around 11 to 15%. And in India, we would have a approximate prevalence of around 12%, with around 2 lakh patients requiring dialysis being added each year. So what is driving this epidemic of chronic kidney disease? It's predominantly driven by various lifestyle diseases. Predominant among them are diabetes, hypertension, and obesity. Chronic kidney disease, unfortunately, does not give any initial symptoms or signs, and therefore, once the symptoms start coming, it's already too late. What so called early symptoms could be having swelling over the face, over the eyes, to get up repeatedly to pass urine in the night, having uncontrolled blood pressure, or in patients who were previously having good control of blood pressure, the blood pressure control becomes abnormal, feeling generalized weakness, tiredness, and aversion to food. Once the chronic kidney stage develops to a larger extent, say to a stage of CKD 5 or 4, you can have itching, insomnia, neuropathic pain, vomitings, and in the end, pulmonary edema, which can be called as a non cardiogenic pulmonary edema. And once the patient reaches a stage of end stage kidney failure, the options are either to go in for dialysis or a transplantation. Dialysis and transplantation, unfortunately, are expensive modalities, and chronic kidney disease by itself, even if it is not into the stage of end stage kidney disease, would increase the cardiovascular morbidity and mortality to the tune of 5 times. So, once we have early detection of chronic kidney disease in place, we would not only prevent so many patients from entering into the cycle of end stage kidney disease, but would also prevent many patients from going into cardiovascular morbidity and mortality. So, early detection of chronic kidney disease is not only important to prevent end stage kidney disease, but also important to prevent cardiovascular morbidity and mortality. And obviously, prevention is better than cure, and this can't be more true for chronic kidney disease. So once we talk about prevention for chronic kidney disease, we should be knowing as to whom all to screen. If possible, everybody should be screened. And among so many of us, how many can confidently say that their kidneys are healthy and functioning well? So we have to increase to this level of awareness that most of us, like doing regular ECG checkup, regular blood pressure checkup, should also look at their kidney health. But if we have to establish a population or a widespread screening program, we would have to limit ourselves to high risk population. And that obviously would be elderly, diabetics, hypertensives, smokers, patients with obesity, patients having family history of kidney diseases, or any past history of renal diseases. So many renal diseases, particularly acute kidney injury, though would normalize and we would think that the kidneys have recovered fully, unfortunately, the renal function reserve has been damaged and the kidney disease would slowly progress
This meeting is being
to
recorded.
subsequent renal failure. So, all patients with acute kidney injury or other renal diseases should be screened for any development of chronic kidney disease. How to screen? Actually, screening for chronic kidney disease is quite simple. You basically have to do three tests. That is to look for microalbuminuria, that is to look for any loss of albumin in the urine, to do a simple blood test to get a urea creatinine or what we call as kidney function test, from which we can have an estimated GFR, and to do at least once ultrasound for the kidneys to know that the kidneys are structurally normal and healthy. What can we do about making prevention for chronic kidney disease more acceptable? We would have to start early in the family, in the community, and the society, raising the awareness, as I said, about the important role of the kidneys in maintaining health. And since it's a silent disease, to sensitize the population to get regular screening of the kidney for the kidney health, to make right dietary modifications, to avoid junk food, to have a balanced diet, to have low sodium intake, low saturated fat intake, avoidance of complex carbohydrates, appropriate intake of fruits and vegetables, moderate the use of edible oils and animal food, avoiding processed foods, and keeping a control on the weight. Having a good physical activity also not only improves your physical health, mental health, but also would prevent chronic kidney disease, hypertension, and diabetes. We all know that smoking is bad for the lungs, causes cancer, is bad for the heart. It's also very bad for the kidneys. And kidneys are basically bunch of micro vessels, and smoking can badly destroy these vessels. And therefore, avoidance of tobacco and smoking in all form is desirable. As I said, patients should undergo regular blood checkup. If you are a diabetic, have a regular blood sugar monitoring, regular blood pressure monitoring, and simple urine and blood investigations, as I suggested, are required for early detection of chronic kidney disease. Since diabetes is one of the very important causes of kidney diseases, good control of diabetes would prevent the kidney failure. And all the patients who are diabetic should have good diabetic control, good glycemic control, and regular checkup for their glycemic control and renal involvement. Another very important cause, especially in our country, is use of unsupervised medicines. So many times the patients would just go to the nearby druggist, the drugstore or a chemist and take whatever medicines they want to take. They would be following so many forms of medicine without appropriate consult from a concerned specialist. And this unsupervised, persistent use of medicines can be an important cause for chronic kidney disease. So, just to conclude my talk, chronic kidney disease is a common problem. It is a serious, it has serious implications not only for the kidneys, leading on to end stage kidney failure, but also for increasing cardiovascular morbidity and mortality. Unfortunately, chronic kidney disease by itself does not have many symptoms till advanced stages, and therefore you have to undertake regular screening for chronic kidney disease. And more importantly, there are so many drugs and so many modifications in the diet and the lifestyle which are available, which can significantly slow or even reverse the early stages of chronic kidney disease. And therefore, if chronic kidney disease is detected early, it is still preventable to form a chronic kidney disease requiring end stage kidney disease later on. So, in the end, I will just leave you with these golden rules of keeping your kidneys healthy. Keep fit and active. Keep regular control of your blood sugars. Monitor and control your blood pressure. Eat right. Keep your weight in check. Maintain healthy fluid intake. Avoid tobacco in any forms. avoid unsupervised use of pills and any medications, and get your regular urine and blood examination done if you have any of the high risk categories. Thank you very much.
Thank you so much, sir, for highlighting how lifestyle changes and early screening of kidney diseases can reduce the transplant burden. Your emphasis on prevention as a national imperative sets a strong tone for today. Do we have any questions? We don't have any questions yet, sir.
Just one question to Sandeep Mahajan, sir. Like in rural areas, particularly when somebody wants to know okay, how early they want to detect a kidney disease early, but where the resources are limited. So, what would you advise, like, for early detection of the kidney disease in a rural setting in a village area, if somebody is having some symptoms and they want to check, they want to, they want this to be halted.
Fortunately, for detection of chronic kidney disease, the investigations required are not complex. Most of the villages or primary health dispensaries would have a routine analyzer to look for the blood urea and serum creatinine values. A simple urine dipstick can tell us about proteinuria, though it might not be as sensitive to tell us about albuminuria, but it can tell us about proteinuria, and a simple ultrasound examination. These regular, easily available investigations can actually help us in screening so many patients with chronic kidney disease. And most of the primary health centers actually are now equipped, and even in a certain national programs, in certain state programs, the ASHA worker or the peripheral healthcare worker can do blood pressure monitoring, can screen the patients who have high blood sugars, high blood pressures, and then can refer them subsequently for further screening to a primary health center or a district hospital. I think so. If we form this kind of hub and scope model in which the most peripheral worker can screen as many population as possible, and then refer the cases by escalating it to subsequent levels, this can screen so many non-communicable diseases.
So we have another question for you. Are there any genetic causes of chronic kidney disease, and what are the ways to mitigate them early?
I did highlight that those patients who have family history of chronic kidney disease are more likely to have kidney diseases. Yes, there are few common conditions like polycystic kidney disease, which is a very important cause of chronic kidney disease. That would be, say, 1% of our total population. So, if you see, they would be causing around 10 to 15% of patients who have end stage kidney disease as a burden. But there are so many genetic causes which are still not completely known or completely evaluated. And therefore, any patient who has a family history of kidney disease automatically becomes a high risk for chronic kidney disease. Even patients who have diabetes, if they have a family history of kidney diseases because of diabetes, these patients are more likely to suffer from diabetic kidney disease. Therefore, the awareness that chronic kidney disease or kidney diseases do run in the family is important. There are many more important genetic causes for kidney disease as well, but they might not be that common to have a general interest.
All right. Thank you so much for an insightful talk.
Thank you. Thank you very much for the opportunity.
Next, we welcome Dr. Akash Shukla for his talk on prevention of liver diseases. Dr. Shukla is a globally recognized hepatologist and director of the Department of Hepatology at Sir H.M. Reliance Foundation Hospital, Mumbai. He is also the professor in the Department of Gastroenterology at KEM Hospital, Mumbai. He has contributed to key national and international guidelines on liver conditions such as hepatitis B and C, cirrhosis, and acute liver failure. He also plays a leadership role in India's transplant ecosystem as director of Protosoto West, and advisor to the government of Maharashtra on organ donation. We welcome you, sir, to present your talk.
Good afternoon, everybody, and thank you so much. I'll request you if you all have access, can you please share my slides from there?
Sure, sir, we'll do that.
So we just heard Dr. Mahajan on a wonderful session, and I think many of the things which he spoke are common to keep the liver also healthy, and I will be discussing them very shortly. Yeah. So I will start my talk now. I'm able to. Can you all see my slides?
Sir. Yes, sir.
Okay, great. So remember that everything that we ingest, inhale, and touch, that is going to pass through your liver. So everything that goes into your body is going to pass through your liver. So you have to be very careful about what you ingest, inhale, or even touch. So the symptoms of liver disease are very rare and they occur very late once patient has developed advanced cirrhosis. And therefore, early diagnosis can happen only through health checkups. For example, a fatty liver on ultrasound, a high SGOT, SGPT, a high bilirubin, elevated gamma GT, or platelets less than 2 lakhs. These are some of the early ways of picking up liver disease early. Now, what causes liver disease? And we know since time immemorial that alcohol is one of the commonest causes of liver diseases. And even today, that's almost 40% of the patients that we see. But remember, which also means that 60% of the patients have other causes for their liver disease. This could be viral hepatitis A, B, C, D, E, and now recently described hepatitis F is going to become a problem in the near future. Then we have what is called as the non-alcoholic fatty liver disease, which is the run-of-the-mill fatty liver in people who don't consume alcohol because of the lifestyle. A lot of medications can cause liver diseases. And in addition, there are some rare diseases like autoimmune hepatitis, Wilson's disease, Budd-Chiari syndrome, and more than 100 other causes of liver diseases. Let's see how we can prevent 95% of these problems. We'll start with something which is extremely common and present in around 2% of the population of the country, and that is hepatitis B virus. Hepatitis B virus is mainly transmitted from mother to child either during the pregnancy or perinatally.
The horizontal transmission in young children happens through close contacts and rarely happens in adulthood. Because of the immunity, even if an adult gets exposure, 95% chance that he'll clear the virus. So it's the children who are going to be at risk, and therefore the emphasis is to prevent transmission in children. And for that, we have a very effective vaccine called as the hepatitis B vaccine, which is containing a viral protein, the surface antigen. Now we also have a recombinant vaccine, which is extremely safe and effective. It is made up from a gene for the HBsAg, which is inserted into yeast or mammalian cells. What we need to really know is the dosage. So for newborns, infant, and children, adolescents less than 18 years, it's 0.5 ml, which should contain 20 micrograms, and adults is 1 ml, which should be 40 micrograms. For those who are on hemodialysis or immunocompromised, the dose is double, 40 micrograms, which is 2 ml. There are several regimens which are followed for different age groups, but the most commonly followed regimen is a 3-dose regimen at day 0, 1 month, and 6 months. Remember, if you forget to take a third dose at 6 months, you can take it anytime within the first 2 years of the first dose. If it is beyond 2 years, then you have to restart and retake the whole schedule. In children, we give it on the thigh, but in adults, we give it on deltoid. The efficacy is much better if you give it on the deltoid rather than giving it on the other sides. What are the response rates? If you complete 3 doses, it is more than 95%. But later the age of vaccination, lower is the efficacy. So if you cross 40 years, the efficacy comes down to around 90%. Between 50 to 60, it is down to 80%. And therefore, it is very important that we give the first dose as part of the National Viral Hepatitis Control Program on the first day of birth, what is called as the birth dose, and that itself is more than 90% efficacious in preventing mother to child transmission. In addition, now immunoglobulins are provided free of cost by the government to prevent this mother to child transmission to all mothers who are having hepatitis B. So antenatal testing for hepatitis B, vaccination of the newborn, and giving HBIG to the newborn on the day 0 of life is what prevents more than 99% transmission of hepatitis B in the community. And the common risk factors like prematurity, low birth weight, small for gestational age, mother being immunocompromised, or presence of jaundice is not a contraindication for the birth dose. So we can give it to practically every single child. For those who already have the virus, under the National Viral Hepatitis Control Program, now the diagnostics and therapeutics are provided completely free of cost across the country. And we follow a very simple algorithm of just HBsAg, APRI, which only requires SGOT and platelet count, SGPT, viral load, and nothing else. So based on these parameters alone, we decide which patients to be treated, which patients doesn't need treatment, and the treatment is provided completely free of cost, along with all the follow-up investigations for the whole life under the National Viral Hepatitis Control Program. Coming to hepatitis C, which is transmitted through either direct blood or fluid exposure, sexual activity, or IV drug use. So these are the 3 commonest modalities. And this can be prevented by safe blood practices, by safe sex practices, and by harm reduction measures, and ensuring that only sterile needles are used. In addition, we screen the high-risk groups, people who have history of blood transfusion or blood products, IV drug users, antenatal mothers, people living with hemophilia or HIV, blood bank donors on hemodialysis, and we screen all these for hepatitis B and C, and wherever possible, we treat them effectively. For Hep C, again, under the NVHCP, we have a very simple regimen. We just do basic tests, CBC, LFT, RFT, and HCV RNA. We don't need to do genotype. And based upon this, we give pan-genotypic regimens, either soft Velpa or soft Decla or soft Velpa Riba. And this is effective again for more than 95% of patients in getting a complete cure from the hepatitis C virus. Remember, hepatitis C is completely curable. In hepatitis B, only 1% get a cure, 99% get very good long-term viral suppression. Now, coming to the major group of liver disease, which is the steatotic liver disease, both non-alcoholic and alcoholic. And this is where I think 1/3 of the population in the urban areas of the country are affected, and almost 20 to 25% of the rural areas are affected. Of those who have a fatty liver, around 30% will develop inflammation, and almost 10% are going to develop cirrhosis of liver, and 2 to 3% will develop HCC. This is how we now call NAFLD. And alcoholic liver diseases are renamed as MASLD, which is metabolic dysfunction associated steatotic liver disease. We have alcohol associated steatotic liver disease. We also have genetic and drug induced fatty livers. And finally, we also have a group of cryptogenic. Those who have both metabolic risk factors like obesity, diabetes, hypertension, and are also consuming alcohol, for them now we use a new term called as MET ALD. And of course, the diagnostic criteria for MSLD are now based on BMI, sugars, blood pressure, triglycerides, and cholesterol, because these are the risk factors. And if you want to prevent this disease, this is what you need to really prevent. So if you see at every stage, even before any damage has happened in stage 0, what we need is lifestyle intervention, diet and exercise. We need to, if required, if there's severe obesity, bariatric surgery. But once damage sets in, once the patient starts getting fibrosis, that is when pharmacotherapy starts becoming important. And but when it is advanced, when the patient has really reached the stage of cirrhosis, then the emphasis shifts to prevention of complications and prevention of progression of the liver disease. Now, there are certain red flags. When you have a routine health checkup, if any of these are present, then that indicates advanced fibrosis or cirrhosis, platelets less than 2 lakhs, GGT more than 45, ultrasound showing coarse ecotexture, dilated portal vein or splenomegaly. If the liver is firm on palpation, SGOT is more than SGPT, and whenever you are in doubt, we must ask for a liver elastography like a fibroscan, which is extremely useful in assessing both the quantity of fat of liver as well as the liver stiffness, which will tell us how much is the damage. How can we prevent non-alcoholic fatty liver disease or MASLD? Weight maintenance. So keep a BMI of in the normal range. 150 minutes of cardiac exercises per week. Control of all the metabolic risk factors like diabetes, triglycerides, hypertension, etc. In diet, avoid saturated fats, simple carbohydrates like sugars, have normal calorie diet. Avoid late night snacking, midnight meals, avoid unnecessary medications. The most important culprit is the ultra processed food, anything that is packaged, so where you just open the packet and eat something. Those are the things which are at highest risk of causing MASLD. Once you already have fatty liver disease, but you still have treatment available now. So in diet, a calorie deficit diet, around 500 calories less per day as compared to standard, and avoiding saturated fats, simple carbs, and sugars. Exercise 250 minutes per week. To prevent, you require 150. For treatment, at least 250 minutes per week, and it should be a combination of cardio and muscles. 6 to 8 hours of good quality sleep is equally important. And fortunately, now we have many drugs available for the treatment of NAFLD. The drugs, simple drugs like drugs for diabetes, which are effective, but also which include semaglutide, tirzepatide, dapagliflozin, your other SGLT inhibitors, pioglitazone, but also you have liver-directed drugs like saroglitazar, resmetirom, and very soon you're going to have drugs which are effective like efruxifermin and so on and so forth. If we summarize, weight loss of around 7 to 10% of baseline causes NASH resolution in a significant proportion of patients. And if you lose 20% of the body weight, then you can actually reverse fibrosis in a proportion of patients. Several drugs can cause liver injury. If you look at some of these drugs like acetaminophen or nitrofurantoin or isoniazid or ketoconazole, heparin, very commonly used, statins, but these can all cause liver diseases. Is, is there any safe limit of alcohol? The answer is no. Any amount of alcohol consumption can actually cause liver disease, and therefore, the consumption of alcohol should be absolutely zero. People often feel that if they have food along with alcohol, then they do not get liver disease. But this is not true. While those who do not take food and have only alcohol, they get very severe alcoholic liver disease and they also get malnutrition. But those who take food along with the alcohol, they cannot escape the effects of alcohol. The effects of alcohol would still be there. Similar, weekend binging versus regular consumption doesn't protect you from alcohol related liver disease. 30% of people who consume alcohol are going to get alcohol related liver disease. Another myth is that wine is good for health or beer is not alcohol and it is safe. Both these are not true. Wine is not good for health. Beer is also not safe. Both of these can affect the liver in the long run. Are there any food substances which can help the liver? So there are anti-aging liver protective food like red bell pepper, broccoli, spinach, nuts, avocado, watercress, what we call as jalkumbi or alif, coffee, which is black coffee, the way it is not had in India, like with milk and sugar, is not the coffee which is going to help you, but it is the black coffee which is going to be helpful. And then certain fruits like papaya, blueberries, banana, citrus fruits, kiwis, apples, and pear. These can help keep your liver healthy in the long run. Most of the liver diseases can be really treated. In the early stages, even cirrhosis can be reversed. But those people who have very advanced liver disease, they would require a liver transplant. And please remember that life would be completely normal after liver transplant for most of the patients. To summarize, my dear friends, for hepatitis B prevention, get vaccinated. Hepatitis C is curable with simple tablets, but with safe practices like needles, blood transfusions, and safe sex, you can prevent hepatitis C. Do regular exercises, 150 minutes to keep your liver healthy. Eat a healthy, balanced diet, normal calories to avoid fatty liver disease. Have zero alcohol. Don't take any unnecessary medications. And liver transplant is required only for those who have end stage liver disease. For all other people, there are effective therapies available in presence of even early stages of cirrhosis. Thank you very much.
Thank you so much, sir. Your practical strategies around the liver diseases remind us that awareness and lifestyle are often the first line of defense. We thank you for your insightful talk. Moving on, please join me in welcoming Dr. Sandeep Seth to share his insights on the vital topic of prevention of heart diseases. Dr. Seth is a professor in the Department of Cardiology at AIIMS New Delhi and is a leading expert in heart failure, interventional cardiology, and stem cell therapy. He has been instrumental in developing and strengthening the heart transplant program at AIIMS. He has also participated in policy discussions and contributed to national guidelines on heart transplantation and organ donation. We welcome you, sir.
Thank you. I would at the outset like to thank Dr. Anil and the entire team of Noto for giving me this chance to talk about a topic which is very dear to my heart, and especially in the month which we celebrate as Organ Transplantation Month. And it was this month was actually chosen because one of the reasons was that on 3rd August 1994, AIMS did the first successful heart transplant done by Dr. Venugopal. And in honor of that, we initially declared 3rd August as the Heart Transplant Day. And later on, the government decided that rather than having a day, we should have an entire month of celebrating organ transplantation. So, coming to the topic, I'm going to talk about not about the disease once it's occurred, but rather prevention of heart disease. Let's just start my slides first. I hope the slides are visible now.
Yes, sir, they are visible.
Okay. So we'll start the topic, and I was given to understand most of the audience would be health professionals. So this will be based basically at the health professionals only. Cardiovascular disease is a major burden in not only in India but all around the world also, and almost 1/3 of all the global deaths occur because of cardiovascular disease. And where maybe a few decades ago, infections, neonatal mortality were the major causes of global death, now gradually the rates of cardiovascular disease, which would include ischemic heart disease and stroke, those numbers are going up and up. As we go into more developed countries, including India, though the rates of acquired diseases like ischemic heart disease, stroke are going up, whereas the causes like infection and neonatal mortality are going down. So, as per WHO data, almost 17.9 million deaths occur annually because of cardiovascular disease, and majority of these are due to heart attacks and strokes. And again, a number of them can actually be prevented by modifying the modifiable risk factors. So this is where India stands. India is responsible for 20% of the global cardiovascular deaths, and the mortality rate in India is relatively higher as compared to the global standard, with the age standardized cardiovascular mortality rates of 272 per lakh population versus a rate of 235 in the rest of the world. Most cardiovascular diseases, as like other diseases, occurs early in India. So it's an early onset, almost 10 to 15 years earlier. So our heart attacks, hypertension, all these diseases will occur almost 10 years early as compared to the Western counterparts. The causes for these cardiovascular disease are fairly obvious to some extent. Dr. Shukla also talked about this. So urbanization, sedentary lifestyle, poor diet, poor awareness. And this is in more detail. So there's something which we can't really change. You can't change the fact that you're aging. As you age, the risk of cardiovascular disease goes up. Males are more prone towards cardiovascular disease. Ladies after menopause also get the same risk. Family history of cardiovascular disease is very, very important. So if you had a relative who's had cardiovascular disease with the early onset, it's not that if you have the cardiovascular disease at the age of 80, that would not count as family history. But supposing it occurs at a younger age, maybe at 40, 45, 50, that amounts to a positive and strong family history. Race, ethnicity. So Indians are more prone. There are some genetic diseases which lead to hyperlipidemia. So those can also lead to more cardiovascular disease. These we can't really control, but what we can control is our nutrition. Both undernutrition and obesity are both risk factors for cardiovascular disease. Then smoking, obviously, then hypertension, hyperlipidemia, easy to diagnose and easy to control. Diabetes, again, should be diagnosed. I'll come into this later, and should be controlled. Physical inactivity, with our development, with our busy lives, starting work from 8 a.m. in the morning till 12 o'clock at night, we really don't find the time to exercise. Alcohol consumption, I think I'll be talking much less than what Dr. Shukla had already talked about. So, what is the prevention? If you switch on the radio anytime, you are hearing again and again and again the Honorable Prime Minister talking about a healthier you. He's emphasizing a lot of our fight against obesity and emphasizing that we should be more active and should be using less oil. This was there in one of the Mann Ki Baats which he talks about every Sunday. The types of prevention: prevention starts from primordial prevention to primary to secondary prevention. Just to explain the differences. Primordial prevention is when you're intervening in the community. You're looking at potential risk factors. So you are looking at sedentary lifestyle, obesity, lack of sleep, diet, smoking, hypertension, dyslipidemia, kidney disease, then stress. So all these factors you're trying to reduce in the community, encouraging children to have healthy food, encouraging everyone to exercise lot more, look at and diagnose the hypertension, control it, diagnose diabetes and control it. So that is primordial. That means no diseases occurred as yet, but you're trying to improve the general health and well-being of the population. Then comes primary prevention. Primary prevention basically means that some event has occurred and is likely to occur. So your risk factors are there. Myocardial infarction, congestive heart failure, these will be the manifestations. So your primary prevention worker means basically you have to look for the risk factors in a individual. Primordial was in the community, primary comes in an individual. For instance, if you are sitting in your clinic and a patient comes to you, he's about 50-year-old, he's smoking, he's diabetic, and he's very obese, has a family history. 4 risk factors, not modifiable, he's male, Indian, 6 risk factors. So automatically, without using any risk calculators, you know that he is very likely to develop a cardiovascular disease in the future, and he will benefit from some preventive measures, which in this case would be a certain amount of statins for cholesterol control. Irrespective of what his cholesterol is, it is recommended you would give him some amount of statins. You may or may not consider aspirin, but as of now, the recommendation is against aspirin. Secondary prevention basically means that the disease has occurred. So, for instance, you had a patient who's had a myocardial infarction, then the preventive treatment and strategies go much higher. You're very aggressive to prevent another event. So, let's look at the risk factors. Hypertension. Hypertension is a major problem in India, and especially because it's a silent disease. In one of the recent surveys which was done nationwide, 28.5% of the population was found to be hypertensive in an adult population. Out of this, only 27.9, that means almost one third, were actually aware that they were hypertensive. And of these, of the patients who were hypertensive totally, only 14.5% were on treatment and only 12.6% were actually under control. That means in this population of 28.5% of our general population, those who were hypertensive, only 12.6% were actually under control. And what is the control? So normally, if you understand blood pressure, hypertension is above 140/90. That's your first target, that you bring the blood pressure down to less than 140/90. But if there is a high risk factor, patient is diabetic, is obese, is a smoker, has a family history, then your targets go somewhat down. So you bring it down to 130/80. Because this is something which you can do fairly well and it's easy to control. So drug therapy, lifestyle changes, modifying your salt intake, reducing your salt intake, increasing your physical activities, standard management of hypertension. Switching on to diabetes, again a major cause of cardiovascular disease. Here also, if you see, the entire body is affected by diabetes, and again it is a disease which is silent. Manifestations usually don't occur unless you are doing regular checkups. You will often miss diabetes until it has already caused some organ damage. So it will affect the eyes, called retinal changes. It will affect the heart. It can cause coronary artery disease, can cause a myocardial infarction. It will obviously affect the kidneys, also cause renal failure, which starts with the microalbuminuria, which can be picked up and then preventive steps taken, or ultimately it will manifest as kidney disease. And of course, peripheral vascular disease. So these are 4 major manifestations of these. And it is better to pick up diabetes before these manifestations occur. Basically, before end organ diseases occur, you want to pick up diabetes. And once you pick up diabetes, you want to use the maximum possible therapy and lifestyle changes in diet to bring the HbA1c at least to less than 7%. Lipid management, once we talk about lipid management, whenever we talk of primary prevention, we are trying to basically look at the risk an individual has. We are trying to calculate the risk a patient has for cardiovascular disease. So it's very simple that you can use one of the risk calculators. You can use for India, the best calculator, one of the best calculators is QRIS 3, because in that you can actually choose whether the patient is from India or otherwise. And based on that, based on the risk which comes, you can take a decision on whether you want to start statins in these patients. So this is for primary prevention. That means the diseases don't occur, but you've got risks. So risk includes patients who are smokers, have diabetes, or they have a relative who's had a heart attack or angina, or there's kidney disease, blood pressure is not controlled. Even things like migraine, rheumatoid arthritis, SLE, and mental disease have also come into this risk calculator. Based on this, you take a decision on whether the patient has risk of heart disease in the future. And this is what you do with the reports. You look at the lipid profile. You classify the patients as low, moderate, high risk, and very high risk. So very high risk are patients, for instance, who have established cardiovascular disease or have diabetes with end organ damage. So here you're most aggressive. Here you want the cholesterol level. Basically, LDL cholesterol is the target. So you want LDL cholesterol less than 55. And sometimes if there's recurrent cardiovascular disease, you want it even less than 40. So practically no LDL cholesterol in the body. High risk will be patients who have markedly elevated single risk factors, for instance, uncontrolled blood pressure or LDL is more than 190. So any one risk factor or prolonged diabetes or any other factors. So in these, the target again is fairly strict. That means you want a LDL of less than 70. If there's moderate risk, for instance, a patient who just has diabetes or on treatment, you would want to consider more often that you should put these patients on statins and bring the LDL down to less than 100. If the risk is not very high, for the rest of the population, if there is some risk factor of disease, then even otherwise, the current guidelines suggest that LDL cholesterol less than 116 is the ideal for a normal person also. So initially these targets were much higher. Initially we used to think that less than 130 is good for a normal population, but now the targets are getting more and more stricter. Supposing you have developed coronary artery disease in any form, angina or a heart attack, then the prevention levels becomes much more aggressive, and we would assess the LDL levels. Based on that, our targets are less than 55 for most patients and less than 45 for patients who have multiple and recurrent disease. And you will start with statins, but you will often escalate to some of the other oral drugs like bempedoic acid or estimate. And if necessary, you can use injectable drugs like PCSK9 inhibitors and inclisiran. So all these are now available in India. Costs are gradually coming down. And it is important to understand what levels of LDL are we talking about and what drugs are available. Switching on to smoking. So again, there is no safe level of smoking. You can't say I smoke once a week or one cigarette a day. Any smoking is bad. In fact, we had done a study in the cath lab where we were doing angios, and whenever we had a patient who was a habitual tobacco chewer, we would ask the patient to chew tobacco, and we would find that the coronary arteries started showing spasm and reduced caliber while the patient was chewing tobacco. So it shows very effectively that it's not just smoking, even tobacco, even chewing tobacco. Once you put nicotine in the body, it is harmful. So the 5 A's of smoking cessation: understand the level of smoking in the patient. Ask, what do you smoke? How much do you smoke? How long have you smoked? Then you give an advice. First, you can try gentle advice, explain the harmful effects of smoking, for instance, cardiovascular disease, stroke, then also explain the more dangerous effects like cancer. You can also frighten the patient by showing pictures, as often happens on the television. Then you try and assess by talking to the patient whether the patient is actually going to listen to you. Then you can help the patient by talking to the relatives also. Maybe you can put him in a detoxification program. And it's more important that once you label a person as a smoker, follow him up. Call him back for a checkup after a week or two, and then see has he taken any steps towards stopping smoking. But it's not just giving advice which is important. You have to follow through and ensure that the advice is followed. Diet, of course, most of this was actually covered by Dr. Shukla. I'll just repeat it. Basically, we prefer for cardiovascular disease a low carbohydrate, low fat, high protein diet with high fiber. So you avoid the use of trans fatty acids, red meat. Again, emphasis is that try and avoid processed food, whether it's food which comes out of a tin or a plastic box. So your chips and all these things go out. Encourage whole grains, fruits and vegetables. Fruits, vegetables, nuts, so almonds, walnuts, even peanuts, fish. These are all good for the heart. Salt intake should be reasonable. You should not add too much salt to the food. You should avoid full fat dairy products. You should avoid red meat. And again, as I emphasized, processed and market products like sweets, burgers, especially the McDonald's burgers with extra cheese, pizza with extra cheese, wafers. So all these are avoidable. You can, if necessary, if you feel like it, take it once a week. Maybe just take a slice of a pizza, or just take half a burger if you really like it. But otherwise, as a regular habit, taking it daily is totally avoidable. Exercise again is something which cannot be overemphasized. With our busy lives, we just forget that we have to exercise. And it doesn't mean that you have to join a gym or you have to follow a trainer with you. 150 minutes of exercise a week basically amounts to 30 minutes of exercise 5 times a week. So if you have your step counter on your phone or you take a smartwatch, basically, even if you take a walk for about half an hour, 45 minutes, you can get easily 1,000 or 2,000 steps in. And plus, if you, during your work day, park your car a bit away, walk 1 or 2 flights of stairs, and generally try to be on your feet more, you can achieve at least 4,000, 5,000 steps easily. And you maintain an active lifestyle. And over the weekends, maybe, if necessary, you can increase that activity, maybe do some kind of stretching exercise. Stretching exercises, a very gentle amount of strengthening exercise using simple, very light weights or exercise band is usually very good. Stress, of course, in today's world with the kind of lives you're leading, stress is a major risk factor for heart disease. That increases the blood pressure, causes vasospasm, causes coronary spasm. So you have to try to help your patients find ways to relieve stress. For instance, they should walk regularly, exercise regularly, maintain a healthy lifestyle, have social connections with friends. Once you go out with friends, obviously your stress levels come down. And maybe you can take things like yoga classes. If nothing else works, connect the patient to a therapist who can at least talk to the patient and try to reduce the stress levels. So, just to summarize, basically, you have primary prevention. Basically, you're trying to protect tomorrow by following good practices today, which will improve simple things like exercise, diabetes diagnosis and control, diet management, avoiding smoking, looking at your cholesterol, looking at your blood pressure, and assessing the risk. Basically, it's a question of numbers. You take out all the numbers that you have, blood pressure, cholesterol, diabetes, all these numbers, and control, keep an eye on the numbers. Secondary prevention, once diseases occurred, you have to ensure that your patients and all of you take your medication on time. You will, after some medicines, you will obviously feel normal and fit. That does not mean that you stop your medicine. Many of our patients actually stop their medicines and then they have a second heart attack. Regular follow-up with the doctor is essential. Once you're very stable, then you can follow up with the doctor, but at least once a year. That is the bare minimum. Initially, when you're sick, you obviously need much more frequent follow-up. And rehab programs are necessary if you had some cardiac damage or even otherwise. Some gentle rehab programs are obviously good for your mental stress also. Risk factors cannot be overemphasized, that these risk factors have to be controlled. For us in the cardiology OPD, we repeatedly found that it's very difficult to make a patient stop smoking. Cholesterol is easy to control. We just put them on high dose statins. Blood pressure is easy to control. What is often difficult to control is diabetes, because some of patients don't realize the importance of controlling diabetes very well. And this needs fine tuning of the diabetes control, but this has to be done. And the patients should have family support. They should have other people who know about the disease. They should also talk to other people who have the disease and get support for themselves. So in conclusion, basically, if you want to prevent cardiovascular disease, you have to act early, you have to screen the patients, you have to counsel the patients once you diagnose the patient, and you treat them properly, aggressively, and follow them up regularly to ensure that their management is done properly. Thank you very much. I'm open for any questions if there are any questions.
Thank you so much, sir. Thank you for reinforcing that cardiovascular health isn't just a personal responsibility but a public health priority as well. Your message resonates deeply with every listener today. We thank you for your insight.
Thank you.
Thank you, sir. Thank you very much.
Thank you, sir. Thank you.
Our next speaker today is Dr. Anand Kumar, discussing on how to set up a disease organ donation program in a hospital. Dr. Anand Kumar is the director of India's apex body for organ and tissue donation and transplantation, where he leads the National Organ Transplant Program and serves as the National Nodal Officer for the Transplantation of Human Organs and Tissues Act 94. A public health expert with over 33 years of government service, he has played a pivotal role in shaping India's organ donation laws, infrastructure, and national registry systems. We welcome you, sir, to present.
Thank you, Dr. Kanika. My slides. So, like after all those talks about prevention of organ diseases which cause organ failure, and these talks, all the talks were very useful talks. And because we not only have to increase the supply of the organ, we also need, uh, reduce the demand of the organs. So, if we focus on prevention, which is the which is the more better strategy to control the organ failure cases. Uh, but still, many cases would fail, and we need to have organ donation in the country. So, how to set up a diseased organ donation program at a hospital? Well, into it, I'll just help with some statistics. Yeah, go to the next slide. So, like this webinar is being held under the Agdan Jeevan Sanjeevani Abhiyan, and the purpose is aimed to increase awareness. Next, please. So we have these mythological examples of organ transplant, xenotransplantation, we can say, of the Lord Ganesha, and then a donation, which is, there in the our mythology, where mythological, everybody knows that Rishi, the Rishi, donated his body and his bones rather, and to make a weapon when the Asuras Sangram was going on. So these we have examples of donation and transplantation in the history. Yeah, next, please. So our honorable Prime Minister has talked about the organ donation in his Mann Ki Baat program, where he has emphasized that one organ donor can save up to 8 lives. So next, please. So India is third highest in the total number of transplantation. This is a comparison of 2023, and India was third highest in total number, and first that is the highest number of living donor transplantation. But if you see the proportion of the deceased donor transplantation in all these graphs, that is the blue bar, which is very low. So we need to focus also on the organ donation, that is to improve the deceased donor transplant number. Next, please. So we have a huge requirement of transplant in our country. The organ failure diseases are increasing every year. Now we have rough estimate of 2 lakh patients, of new patients who will require kidney transplant, getting added to the pool every year. Similarly, liver also around 15,000, heart also 50,000, and this is the waiting list we have in the total 97,000 patients in the waiting list. Last year we have done 18 previous slide 18,910 transplants, and even we there was a report from the hospitals of death of around 2,636, which could be, they died waiting for the organ for transplant. So that is a very, you can see the situation is very grim, and that out of these 18,910 transplants, around 3,400 transplants were for the deceased donors. So our numbers are increasing, but we need to do much more. Next, please. So this is, you can see the numbers are increasing over the years, and we have reached 18,910 last year. And next, please. And 1128 donors last year, and these are tentative figures of the last year because still some of the hospitals have not given us the complete information, and but this is what we have estimated. Next, please. The number of disease donor transplants last year was 3,403, and this was a 16% increase as compared to the 23. So when it was 2,935, so 16% increase in the transplant numbers which were done from the deceased donors. Next, please. So many of you are aware that I just displayed what is the motto and what is the three-tier structure, how the network functions. So motto is basically the apex organization, National Organ and Tissue Transplant Organization, and the Government of India, and it basically is responsible for policies, guidelines, SOPs, and maintaining a data registry or data bank, maintaining the data of the people who have pledged for organ donation, organizing training and coordinating with other institutes for training, and coordinating for no, procurement and distribution of organs, and awareness activities at national as well as in we have our regional and state organization which also are involved in all these activities, and also whenever there is a research in organ donation and transplant area, that is also gets involved. Next, please. So next, please. So we have motto and national, and then regional, and then state level, and these network with transplant centers, retrieval center, and tissue banks. So currently, this network has more than 1,000 hospitals. So and currently we have our state level organization. Basically, every regional organization is also a state level organization. So 31 states currently have a state level organization established therein, and some of them are very recent in northeast part of the country. And we are trying to have an organized network connecting with all the hospitals which are doing transplants and retrievals as well as banking of the tissues. Next, please. So, whenever a patient who requires a donor for transplant, donor organ for transplant, and from a deceased donor, then he has to get registered because all these hospitals they have a unique ID, which are now around 1,000 hospitals, which are either doing and more than 700 are transplant centers. So they are having login ID and passwords, and these given by the NOTO. So any patient who requires an organ for transplant is registered by these hospitals, and there then the waiting list is generated, which will be like hospital list, state list, regional list, and then it can be a national list also. And whenever a donor comes, the information goes to the concerned state organization, and the state organization then looks at the waiting list and distributes those organs as per the like giving priority to the Indian patients and to the local patients who are there in the donor hospital. And we also register the foreigners, like whenever there is a foreigners who are receiving treatment in India, but organ is only allocated to foreigner if there is no Indian taker in the entire country. So that is how the entire framework works. Next, please. Next. So all of you are aware that these are the common organs which can be donated. Like these are all 6 vital organs. We have kidney, liver, heart, lungs, pancreas, and intestine. And next we have various tissues like cornea, heart valve, skin. Skin is also now very commonly being used after donation, and bone is also being used. So then there are many other tissues which can also be used. Next, please. And we now have, hand transplants are also being done in our country. We are the number 1 in the entire world in hand donation and transplantation. And many patients have benefited from hand donation. Next, please. So you can understand that how important donation is. But how to set up a donation in a hospital? Whenever you have a hospital, and basically every hospital which wants to do donation or retrieval and for transplantation, they have to obtain a certificate of registration from the state authority. So that is called appropriate authority, and that certificate of registration is sort of a license to do the organ donation or retrieval. Without the license, you cannot even touch the any any patient for organ donation. So organ donation first thing is the license that is issued by the state government. Next, please. Next. So, uh, so what are the various actions the hospital once it has got the license? They first need to have a nodal officer in that hospital with which various agencies like SOTO, ROTO, or NOTO can talk directly. We cannot talk to so many patients, so many people in the hospital. We need a nodal officer who should be a doctor. Then every hospital need to have transplant coordinator, and these transplant coordinator is mandatory as per the law also, and they should be, every ICU should display the name of the transplant coordinator, the contact number, as well as the name of the nodal officer. So, and there should be a brainstem death certified by a board, which is, again, the members of the brainstem death certification board are to be approved by the state appropriate authority, and then the hospital should ensure that these brainstem death board members, they and the transplant coordinators, they have to be trained. They cannot be like anybody doing the brainstem death certification. The law has provided that you can do the brainstem death certification, and and these, but still the hospital, because most of the doctors are not used to certifying brainstem death, so they must receive some kind of a fresher training. Then we also say, as per the law, it is required to request for organ donation. So once they are required to request for organ donation, so those kind of boards to facilitate those requests should be put up at various locations. And in the organ donation program, it is very important to involve the neurosurgeons, neurophysicians, or the trauma care, trauma care doctors, like, because most of these donors, from where will they come? They will come either from the road traffic accident victims or the devastating brain injuries, which could be like a cerebrovascular accident, brain hemorrhage, a big infarct. All those patients, like, they pass through the stage of the brainstem death, and they need to be identified by these experts, or whenever the neuro experts are not there, then anesthetists and intensivists could also be certified, could also identify in their place and certify. So that is also provided under the law. So that because there are, it is already there in the Transplantation of Human Organs Act that who can certify. So there are 4 doctors who need to certify that we all, and that board has to be, put in place, and should be, their members should be known to everybody who are these board members who can do the brainstem death certification. Next, please. So then after the hospital has received the license and has all these systems in place, they all are required to link with the NOTO registry. And it is very simple. They can, if they have any difficulty, they can call our 24 by 7 call center, and they will facilitate their registration. And they can go to the website and simply create a user ID password, fill up the form, and just take it print out and send it across, certified by the, signed by the head of the institution, and we will link with the national registry. After the link is there, they have a login ID already like created by them, and after login, they will be able to register their patients in the waiting list. Then we also say that at least to the begin with the program in the hospital, they should organize one day a CME for everyone, not only for doctors but nurses but other staff also, that everybody, the entire hospital is sensitized towards organ donation. Then the hospital need to carry out awareness activities for the public who are visiting the hospital, as well as the public in the catchment area. And they also have to ensure whenever the organ donation program is there that the systems and logistics for maintenance of cadaver, that is the deceased donor, retrieval, transportation, and storage are in place. And then every data and information about the persons who receive organ or donate organ, they need to be sent to the national registry. It is now mandatory to have a noto ID. Without the noto ID of the patient, we will not allocate any organ to any patient who doesn't have a noto ID. So that is now mandatory to have this noto ID for every donor, whether it is a living donor or whether it is a recipient donor. So every data has to be shared with the national registry. Next, please. Next. Yeah. So what does the nodal officer role is? That nodal officer will put in place a system of organ donation in the hospital. He will make all these arrangements for OT, ICU beds, etc. Like whatever deficiencies are there, and they can seek funds from under the National Organ Transplant Program. He will also organize trainings for the transplant coordinators. He will also supervise the work of transplant coordinators, organize CME, etc. Next, please. Next. So, like every hospital should have some kind of a protocol for brainstem death, put in place. Brainstem death, such kind of forms they can be put up in the ICUs for knowledge of everyone. Like what are the various prerequisites for brainstem death which need to be fulfilled, and then absence of the brainstem. Then what are the tests for absence of the brainstem death, reflexes, and how the FPA is to be conducted. These are the important steps that in the brainstem death. So these protocols or SNPs should be known to everyone. Next, please. So then we say from Noto side that we should have two kind of alert systems, and these alert systems can be generated through the WhatsApp groups. So alert is one should be a hospital internal alert system, and the second should be a hospital external alert system. So internal alert is generated by the ICU doctor from the ICU where the patient is admitted, who who could be a potential donor, and in the ICU the doctor or the nurse on duty, the critical care nurse on duty, they can generate this alert. Like suppose my protocol says somebody has Glasgow coma scale of 3. So, and there is a known cause for this coma. And then we want to, this brain death team to come and check for the presence of the. So they will generate that there is a possibility of a brainstem death situation here in this ICU. So this ICU doctor preliminary identifies, or the nurse can also trained enough can identify, and they send this alert to the organ donation team. The organ donation team means the nodal officer, the transplant coordinator, the brainstem death committee experts, forensic medicine expert. So the message goes to everyone. There is a, and they should automatically move to this ICU. Brainstem death experts check for the apnea. So brainstem death committee comes, they check who the first apnea, and if the first apnea is positive, then the transplant coordinator should come talk to the family, and they basically they may not request donation at this stage after the first apnea, but at least they will explain the situation that the patient has been found to be brain dead, and they will check again after 6 hours. They build a rapport with the family, they give support to the family, and then so transplant coordinator will come into picture right after first apnea, or even if when the organ donation team is given the alert, they can even come earlier also. So that is very important, uh, that they should. Uh, so I think uh, please share the PPTs. Yeah. So so then there is a then the organ brainstem death committee will further conduct the second apnea test and do the grief calls. Then the transplant coordinator, somebody has to explain to the family the person is dead. And once the brain's second apnea is positive, Then there is a grief counseling procedure by the even that is done by the transplant coordinator. Then they genuinely request for organ donation, and consent process is there and donor screening is there. That whether the donor is fit to donate, also the organs are healthy or not for donation. Then what is the then second is the hospital external alert system. We say that after the first apnea has been there, positive has been found, send the tentative alert to the concerned state level organization. The SOTO will get activated. SOTO will start identifying the recipients so that the time is not wasted. And SOTO even can decide who will be tentatively allocated these organs who are being offered, who could be offered for donation. So we want every such hospital to who wants to start a organ donation program to start these two alert systems: hospital internal alert system and external alert system. Next, please. So there are, these steps are there. These steps, donor identification, brainstem death certification, which is done in Form 10. Then informing the family members who will inform, mandatory donor inquiry, and it can start even before brainstem death certification, counseling, including grief counseling, consent, form number 8, donor screening, medical legal clearance. Next, please. So there are various steps involved. Then maintaining donor optimization, maintaining the donor in the best of physiological condition, arranging the OT and retrieval teams, entering all the details in the online format, SOTO information, and then so many steps are taken care by the SOTO. Then organ retrieval, preservation, tracking, documentation, transportation. We have issued SOPs for organ transport. They are available on the website. But again, I would say do not forget tissue donation. Even if the family has refused organ donation, please request for tissue donation like cornea, skin, bones, and then do tissue retrieval and coordinate with the concerned tissue banks for depositing those tissues and hand over the body with the most of the respect and body disposal norms. So all these, for each of these steps, protocols should be decided by the hospital, and accountability is also decided that who is responsible for this step, and then the hospital will this should be available written document with every hospital wants to set up a deceased organ donation program, and these protocols should be put in place and should be effective, should be known to everyone, and accountability is also decided. Next, please. So these are the kind of required request board that we say Avashyak Anurod board, which should be put up outside the ICUs as well as at other locations where it is written that the doctor or transplant coordinator or counselor on duty, they are required by law to request for donation of organ and tissues. Next, please. Now we are tracking, as I told you, we are tracking every donation and transplantation by ID, photo ID, both for donor and recipient, and for both living donor as well as these donors. Every hospital, whether the hospital is a transplant hospital or a retrieval center, they all must vote deceased donation. And so that is mandatory. We have requested everyone to do that. Next, please. We are also working on cornea donation and transplantation system of registry. Next, please. So and every hospital should have awareness, activities. So what could be the awareness? Next, please. So why we need, disease donation? That one thing every hospital should emphasize, that living donation alone cannot fulfill the requirement. In certain organs, we cannot take from the living persons. We have, 1.73 lakh deaths in this country from the road traffic accidents. And this is Ministry of Road Transport data of 2023. And many stroke patients who are there, so which could be potential donors. Next, please. So there are many myths and misconceptions. We need to take care of those myths and misconceptions. Like for means are regarding the disease donation. I may be born without organ in the next birth. My religion doesn't allow. Like in Quran, they like if I have to quote Quran, Quran mentions that if anyone saves a life, it shall be as though he had saved the lives of all, so all mankind. So there is no religious part. It is only in our mind, and my culture doesn't allow. That is also wrong. Say no culture bar, restricts any kind of organ donation. Similarly, there are myths about living donation. I will not be able to work. I will fall ill. I will not be able to marry, and I will not get a job. If I donate, I'll be handicapped. But there are, many programs being organized like transplant games. These people who donate organs and who receive organs, they are participating in international level games, and they are displaying how their lives have transformed and they are able to perform now. So all these are just myths. We need to get over them, and we need to dispel all these myths and misconceptions. Next, please. We have a 24 by call center. We request you all that if you need any kind of information about organ donation, please call this call center 1800 We have a website noto.mohfw.gov.in, and we have more than 60 lakh people already visited this website. So it's very frequently being visited. Next, please. And then we have a separate website for organ donation, that is registering the organ donors. Next, please. We are now paying tributes at the time of donation, so that is part of the program. Next. Many organ donation awareness activities from the program side. We are next. So basically, what we say that Mrityu Avashyam Bhavi, everybody has to die. No, we will not be, there is no one who will not die. So, but death is an inevitable truth. But can there be life after death? Like from Noto side, we say yes. Next. So, why burn or bury our organs when we have option to donate and save lives? So, every hospital has to promote this. Every individual, they should, adopt this. Next, please. So do not take your organs to heaven, for heavens know they are needed here. Next, donate organs, save lives. So this is the prime message from motto that Angdan Jivan Dan, and Angdan Jivan Sanjeevani Abhiyan is the campaign this time we are doing. Next, एक खामोशी अनेक मुस्कान, आओ करे अंगदान, पुण्य मिले सब दान से, पुण्य और जीवन दोनों मिले अंगदान से. Next, please. So to facilitate people to pledge for organ donation, this dedicated website for pledging has been made operational, and it is a Aadhaar link pledge. There are just 5 steps for pledging. You can just run the video. Like it is, you have to just enter. There are 5 simple steps to pledge for organ donation. Go to the website, click register for pledge, and pledge using your Aadhaar number, and you will receive a OTP, enter, and then enter with you will form opens. So this is how the voice. Okay, sound is not. So this is how. Click here. You enter the bar, verify with the OTP, and next. Yeah. Yeah. So the form opens. Start. So form opens. You have to enter simple details. Name the parents. What organs and tissues you wish to donate. So then you will again receive one more OTP to verify that you have you are submitting correctly, and name of the motivator also you can enter. And then once you have you can download your e certificate, and happy to inform that since 17th September 2023 we have more than 23 lakh people, 3 lakh 10,000 people who have pledged for organ donation. And this is the QR code which is displayed now. You can all scan and do this. It is very easy, 1 minute exercise only, and you all must do it. Why we need to register as a pledge? Our pledge, because now we are alive and kicking. So we are conscious. We know what we are doing. And tomorrow, when we'll be in some ICU, times unconscious, somebody else will decide it is going to be done with our body and what we are going to do. Like that will be decision of somebody. So we can at least register our wish so that the people after they are died, so the hospital can talk to the family that this person wanted to donate organ, and it is their responsibility to fulfill that wish. Go to next. So thank you so much. This is all I wanted to say. Basically, the talk was directed towards all the medical colleges and hospitals who need to set up diseased organ donation program in their hospitals and have organ retrieval centers. So there is a question in the chat. I can see that whether the family consent is taken required before apnea test. So that is not legally required for apnea because that is a medical decision, and so legally it is not required. Uh, yeah, legally only you require consent for organ donation, not for apnea. So we can go to.
Thank you, sir, for demystifying the process and sharing actionable steps. Your blueprint for setting up successful hospital-based programs will surely help institutions in real-world implementation. Now we turn to a topic that's foundational yet complex, that is brainstem death and organ donation. We are honored to have with us Dr. Rahul Pandit, Chair of Critical Care at Sir H.N. Reliance Foundation Hospital, Mumbai. Dr. Pandit is a nationally recognized critical care expert and a leading voice in India's intensive care and organ donation landscape. He's a visiting consultant at Bathurst and Wagga Wagga based hospital, Australia. He's a member of the Maharashtra COVID-19 Task Force and was also appointed by the Honorable Supreme Court as a member of the National Task Force. We welcome you, sir, to present your topic.
Hi. I'm not able to, let me see, I'm not able to share the presentation for some reason. Let me just try it again. Have you shared that or?
Yeah, we have shared that, sir.
Okay, no worries, that's fine. So I will just request you to change this to the next slide. So good afternoon, everyone. Thank you very much, Director Noto and the team to actually allow me to speak on this topic, which is close to my heart. Over the next 25 minutes or so, we will try and cover up brainstem death declaration, and I'll give a few hints about organ donation, sorry, maintenance of a donor, and then we can take some questions. Next slide, please. So whenever we talk about organ donation, the first thing which we need to be very clear in our mind is what is death, and there has to be a clarity in terms of legal. Our Act of 1994 actually talks about definition of death, and it says that deceased person is a person in whom permanent disappearance of all evidence of life occurs. Hello, can you hear me? There's an echo happening. Somebody's mic is on, so if they could just, yeah, that's better. Okay. So does this person, the person in whom permanent disappearance of all evidence of life occurs by the reason of either brainstem death or in the cardiopulmonary sense at any time after live birth has taken place? It further defines that a brainstem death means a stage in which all functions of brainstem, and I would like to emphasize here, we in India follow the brainstem death criteria for declaration, do not follow the whole brain criteria, which some of the states in US follow and some of the countries follow. And we essentially try and prove that the brainstem has permanently and irreversibly ceased to function. And that's when we declare a patient brain dead. And the Act actually goes on to describe what would be the process required for that. And I'm going to take up those processes in and a bit of a nuances with that. Next slide, please. Keep on moving. So we all know that when we talk about brainstem, it is the three organs, the midbrain, pons, and the medulla, which actually then goes, the medulla again progresses on to become the spinal cord, which sort of represent the brainstem. So the midbrain, the pons, and the medulla are the ones which we actually talk about. And this is the place where all the 12 cranial nerves come out from. And this is also the place where our respiratory center is present. Hence the irreversible cessation of brainstem function makes a lot of sense because it takes away all our basic reflexes with which we are born. So next slide, please. Next slide, please. There are two more presses on that. Thank you. So whenever we decide to declare a patient or think that this is a possible brainstem death patient, I think the first step we need to be clear in our mind is that does this patient have a diagnosis which is consistent with a progression towards a brain death? And if that diagnosis is not clear, take a step back. And the diagnosis should be consistent with progression to brainstem death, not only clinically, but also more importantly, radiologically. Now, the Act does not talk about that, but I would say that we all prefer to see a CT scan like this, where you either see a hypoxic brain injury or a massive intracranial bleed or a subarachnoid hemorrhage or an infective etiology. I will try and share myself if I can see, if I can do that. Yeah, I'll share myself. Can you see my slides, please? Are you able to see my slides, sir?
Yes, sir, we can see. We can see, sir.
Thank you. Thank you. Right. So that's easier now. So you need to be very clear in your mind that you have a diagnosis, and preferably the diagnosis is confirmed by a radiological imaging, which would be either a CT scan or a MRI. And if you have a diagnosis which actually clears that, and it sort of importantly diagnoses what you have clinically thought or what the patient history goes across, then you can go ahead. If there is no clarity, take a step back. Especially there are mimics, severe poisoning, toxicities, abnormalities in your electrolytes, which could mimic something what we would call as a brainstem mimics. And then that kind of a condition would not have an abnormal CT or an MRI. Hence, we need to be very, very clear what we need to actually talk about. Okay. Now, what is the mechanism of cerebral death? We all know the Monro-Kelly doctrine. I will try and simplify the Monro-Kelly doctrine. Monro-Kelly doctrine means that brain is a fixed compartment, and if you have a neuronal injury, the brain starts to swell up. The swelling basically causes an increase in the intracranial pressure. The Monro-Kelly doctrine says that there are three components of the brain. One is the CSF, the other is the brain matter, and the third is the blood which flows into the brain. Now, when the brain swelling sort of increases and your intracranial pressure sort of starts to increase, it actually happens at the expense of the blood flow, and your blood flow starts to decrease down, and it becomes a catch-22 situation where it keeps on feeding one is to one over the other until a point where intracranial pressure becomes greater than your mean arterial pressure. And that's when it becomes incompatible with life and you have no flow in the brain. And that's when the coning happens, the Cushing's reflex happens, and the patient essentially dies. That's when we tolerate that brainstem criteria, brainstem death happens. Now, how do you establish that? How do you document that? The law has given us the three important steps, and all these three steps are very important. Quite often, people talk about apnea test, which seems to be the one which seals off as a final diagnosis of brainstem death. But I think all the three are very, very important. So you have irreversible coma, you have irreversible loss of brainstem reflexes, and then you have cessation of respiratory center. And these three are to be documented clinically. If for some reason you are not able to diagnose or document any of these three steps, then scientifically there is a very clear understanding that you could demonstrate a cessation of intracranial blood flow. But our act is silent on this right now. So in India, if you have to declare a patient brainstem death, you have to follow the clinical documented criteria, which is document irreversible coma, document irreversible loss of all brainstem reflexes, and document cessation of respiratory center function. So let's go one step at a time. The first step, as I said, is there an underlying cause which is inconsistent with the patient progressing on to brainstem death. If that cause is yes, then start looking for any other uh, uh, mimics which could be there possibly. And those mimics and confounders, if they are not there, then you start looking at secondary causes or secondary confounders which may basically preclude you from doing a brainstem dead testing. So what are the secondary confounders? These secondary confounders could be that you may not have your patient in a physiologically normal condition, which means that you may have a patient who is severely hypothermic. Brainstem patients do not have the capacity to keep their body warm, so they often very, very quickly cool down to the ambient temperature of the room. And if your core temperature goes below 32, it is severe hypothermia. Between 35 and 32, it is hypothermia. It is mild to moderate hypothermia. Some of these patients may have severe profound hypotension and may require vasopressors. And if the blood pressure is below 100 millimeters of mercury, have a little bit of a red flag. You may want to optimize that to have a blood pressure which will be either mean arterial pressure of 65 to 70 or a systolic pressure above 100. Always, always, always rule out drugs, poisons, sedations, neuromuscular blocking agents. It's very easy. Wait for 5 half-life cycles of any sedative which you may have given. If the renal function and the kidney function, the liver function is normal. If the liver and kidney functions are not normal, then you may have to wait longer. Alternatively, you may have to consider even interim dialysis if the patient is not going to have a very quick reversal of the sedation which you have given. Neuromuscular blocking agents, those who are anesthetists would understand that doing a train of four response, if there's a question that there was a patient who was on neuromuscular blocking agents today or infusion, and you're not sure whether the effect has gone away or not, you could do a train of four response using a peripheral nerve stimulator, and that would actually allow you to understand whether the patient still has a blockade or no. Four twitches allow you to say very confidently that there is no action of neuromuscular blocking agent. Always make sure that your patient's electrolytes are within the normal range, which means sodium, potassium, and chloride. Make sure that the sugar is good and there are no acid base abnormalities on a ABG. So ABG becomes a very important aspect when you're diagnosing patients with brainstem death. And then comes your next step, which is to actually do the complete neurological examination. And I would again insist that all the three steps are important. Now, who does the testing? Now, usually, what we do clinically at bedside is when a patient comes to us or the patient has been in ICU, and I see that there are no recordable brainstem signs or reflexes by the bedside nurse or doctor, and I start looking at the preconditions and the confounders, and if the preconditions and confounders are satisfactory, then I would say that at least 6 to 8 hours I would wait before even I decide that I want to do a brainstem dead testing. I would also like to emphasize that by this point, I have already spoken with the family several times, and there is a reasonable rapport, and I've understood and identified the family members who are the main players at the same time who are the next of kin. And what I usually do is I actually sit down with them. There was a question which was raised to Dr. Anil Kumar sir that do you require a consent for apnea test or brainstem dead testing? When the rapport is very good, I actually walk them through the test completely in the room when I'm explaining them. And what I usually use as a buzzword for them to understand is that I am going to test those reflexes with which you were born. So a person who is non-medico, for them this sentence sort of makes a lot of sense. I further go on and explain to them that I am going to test only those reflexes which will be present even in the baby who is 1 second or 1 minute into this world. And I then go on talking about the pupillary reflex, the eyelash reflex, the cough reflex, the pain reflex, which is the grimace or the localization, and then I go on to tell that what is apnea test and try to make them understand the importance of apnea test. And I tell them that it is breathing which basically means life and it's not the heartbeat. I go on to explain them that when a baby is in the mother's womb, around 6 to 8 weeks into the pregnancy, you could actually hear heartbeats on ultrasound. And the doctors tell you that the baby is healthy. But we do not celebrate the birthday of the baby on the 6th or 8th week when the heart sounds were heard. We celebrate the birthday of the baby when the baby was born. And what was different when the baby was born? The baby started breathing. So it is the breath which actually defines life, not the cardiac status alone. And while the breathing is continued with the mother's help, while the baby is inside the mother, when the baby is born, the baby has to breathe for himself. And when you lose the activity or lose the capacity to breathe by yourself, that is when you declare you basically are dead with all the other criteria have been satisfied. Then I tell them that two doctors would be doing the test and two doctors would be observing it. The two doctors do the test at least 6 hours apart. It can be a neurologist, intensivist, neurosurgeon, or any other physician who is experienced. And there are two other doctors, which is the primary physician and a hospital administrator, who are witness to it and who sign the document along with the two doctors who are performing the test. So this all goes into a preamble. So organ donation, even before I have started to think about doing a testing, all of this hard work goes in for several hours before we do it. Now let's come up to the testing. As I said, three important steps: documentation of coma, absence of brainstem reflexes, and documentation of apnea. So what do? We document coma by absence of motor response to a standardized deep painful reflex. And we have to be aware of the localized spinal reflexes. That's something which I mentioned to the family as well. It's not uncommon that we have seen spinal reflexes happening while I'm doing the testing. And me personally, I invite a family member to see when I'm doing the brainstem dead testing. And it actually has helped me because it helps me to sort of convey my message to the family clearly. And when they see that the person is not moving to the pain, all the reflexes are absent, is not breathing despite best of the attempts to disconnect from the ventilator and wait for a long time, the penny drops and the acceptance of death happens. Only when the acceptance of death would happen, the next step of organ donation can be even broached. If the family has not accepted death at all, no matter what you do, they will never be able to come up to the point of deciding for organ donation. So the death acceptance happens very nicely if they actually see the donation happen, they see the brainstem dead testing happening in front of them. Coming back to that painful reflex, it is important to give a painful reflex in an area which will be afferent and efferent, both by a cranial nerve distribution. So the medial canthus of the eye, where the ophthalmic branch of the trigeminal nerve is there, or the trapezius squeeze, where you have a spinal accessory nerve, which acts as the afferent and efferent, or the anesthetic would do a jaw lift, which again is a trigeminal nerve reflex. All these three are very, very painful stimulus. And if you see a grimace on the face or a movement of the hand trying to localize or flexion, you would be sure that there is some pain is being pursued by the patient. If there is absolutely no response to this standard stimulus on both sides, you are very, very confident that this is basically inconsistent with the absence of painful stimulus, which is basically irreversible coma. Now, be aware, do not give a sternal rub. Sternal rub usually stimulates your spinal dermatomes and may actually stimulate the spinal reflex on the arms and limbs. And you may then be confusing yourself and thinking that the patient moved when I gave deep painful stimulus. So, where to give a painful stimulus? In the area of cranial nerve distribution. Then you go across and do a documentation of pupillary reflex, oculocephalic reflex, oculovestibular reflex, corneal reflex, cough reflex, gag reflex, one by one from caudal to rostral. So both eyes, you need to do a pupillary reflex. Both eyes, you need to do a corneal. You need to put in a torch, take a thumb depressor and a cotton swab to actually go and touch the posterior pharynx to see for a gag reflex. The law has given us the authority to do it clinically and correctly. So do not just move the tube and say that there is no gag reflex. Do a good attempt by putting the tongue depressor, visualizing the posterior part of the pharynx, which is the soft palate, and then touching that soft palate to see whether there is any gag reflex or not. Similarly, cuff reflex becomes easy because all of these patients already are on the ventilator. So you just need to put in a suction catheter all the way down till it touches the carina and give a couple of pushes. Always expose the patient adequately to see any response on the abdomen or thorax of a cough, so that you are able to have a complete justification of your actions when you are doing this and you are documenting that there was no cough seen at all. For a vestibulo-ocular reflex or a dorsal movement, is something which is optional. We may not do a dorsal movement if there you are going to already do a cold caloric test. However, dorsal movement should be done with caution, especially in patients of trauma where you may not have a clarity about a spinal fracture. Because if you by chance worsen the spinal fracture, then it will compromise your apnea test, because a high cervical spinal fracture will not allow you to complete an apnea test because the diaphragmatic innervation is C3, C4, and C5. So I would say, rather than doing a dorsal movement, a cold caloric test by confirming that there is no wax in the ear and the eardrums are intact would be a much more safer test to do, and look for a skew deviation of the eye on the side of the reflex. Always use ice cold saline close to 0 degrees, and always use at least 50 cc of saline, and watch for 1 minute for the eye movement to be there on each side. So do your test with complete clarity. Once you have done the first two things, which is documented coma and there is absence of brainstem reflexes, then you go on to do the apnea test. Now, what I do is I start my patient's testing. I put the patient on 100% oxygen 10 minutes before I even go to the bedside. I ask the nurse to do that. And as soon as I'm at the bedside, I obtain a ABG. That ABG tells me about the acid base. That ABG tells me about the PCO2. That ABG tells me about the PO2. That ABG tells me about the electrolytes. So I try to keep my PCO2 as close to 40 as possible, so that I have to only wait for a specified period of time for it to go above 60 millimeters of mercury or not. And then what do I see? I adjust my ventilation accordingly so that the PCO2 is 40, or maybe slightly above or slightly below 40. For each minute of apnea, the rule of thumb is that the PCO2 would rise by around 3 millimeters of mercury, 2 to 3 millimeters of mercury. So if I start with a PaCO2 of around 40, for it to go above 60, I will require around 7 to 9 minutes, somewhere between that of apnea time, so that my PCO2 will rise above 60. Now, there is a provision in the law which says that you use 20 above the baseline. Now, that provision should not be misunderstood. So, you can't start with a PCO2 of 30 and go up to 50 and say that I've gone 20 above the baseline. No. What we are trying to do with an apnea test is we are trying to stimulate the brainstem function of the breathing center. Now, the breathing center gets stimulated by the presence of acidemia. And the acidemia only happens when you allow the PCO to go above 60 millimeters of mercury or 20 above the baseline in a patient in whom you are not able to get. That means there are patients who are CO2 retainers where the PCO2 may be around 50, 55 to begin with. For them, 20 above the baseline would be something which would create adequate amount of acidemia in the blood. Remember, CO2 retainers are well compensated in their pH. And if there is no acidemia which you have documented, then you will actually not have the test done correctly. So please do not get swayed away by this 20 above the baseline. You start with the PCO2 of 40 plus or minus 1 or 2, and then document it above 60, which will be correct. If not, you go to go 20 above the baseline if the PCO2 cannot be brought to 40, and if it remains above 40. Now, once this is done, I disconnect the patient from the ventilator, put a small suction catheter attached to an oxygen flow meter, and run between 2 to 4 liters of oxygen through that, sometimes up to 6 liters, not more than that. We also need to take care and make sure that the diameter of the endotracheal tube and the size of the catheter have to be proportionate. So I usually take one third the size of the one third the size of the catheter should be the size of the diameter. So of the tube. So if the tube is around 8 centimeters, size 8 tube, I would take 12 number or a 10 number catheter to put my oxygen through it, because if you put a too big a catheter inside the endotracheal tube, you would find that it actually causes a one-way valve effect and may have hemodynamic consequences on it also. Secondly, also, if you do very high flows through the oxygen catheter, you may actually have some partial diffusion going on and would find that the CO2 does not rise very quickly, and the apnea test would continue for several minutes, and still the CO2 would be very, very low. So I think these nuances have to be understood. In patients in whom the apnea test can be difficult because they are hypoxic, a Bain circuit with the valve kept half open can be used very effectively. The bag of the circuit actually helps you to understand if there are any breathing efforts or not, and the valve kept half open allows some PEEP to basically be extended onto the lungs so that the hypoxia does not set in before the apnea test is completed. The brainstem is confirmed Once the second specialist completes the test and the time of the death is the end of the second examination, which is usually the ABG, which is done on the second examination, which shows that the PCO2 has gone above 60 millimeters of mercury or not. So you sign a death certificate even before you think about sending the patient for a organ donation, or a request for organ donation has to be made. That would be the ideal way. Now, what's the more practical way? The more practical way is that once my first test is confirmed, and I am of the school that me along with my donor coordinator, we all go. I take it as my own responsibility to diagnose death for the patient and also to break the news to the family. I think as an intensivist, it is my responsibility to talk to them and tell them what is happening. And then when I have a acceptance of death coming in from them, if it happens after the first test, fine. Otherwise, I would wait for the second test and then say that I've done the confirmatory second test. Now it is basically brain dead, I can say legally. And that's when I would allow them to have some time to basically absorb the information, to understand and accept death. Once the death is accepted, only then I would bring up the donation topic. Otherwise, no. Some observations which are compatible with brain death: spinal reflexes, sweating, flushing, tachycardia, normotension without pharmacological support, absence of diabetes insipidus. All of these are compatible brainstem reflexes. Incompatible are patients who have any kind of a posturing, either decerebrate or decorticate, extensor or flexor motor posturing, or seizures. They are not compatible with brainstem reflexes. I'll just take 2 or 3 slides of how to maintain a donor and a little bit about ancillary test. When would you like to do ancillary test? You would only want to do an ancillary test if the clinical testing is not possible. For example, if you've got fractured facial bones not allowing the eyes to open, you've got a CSF for rhinorrhea, or you've got a high spinal fracture, and then the apnea test or a clinical examination could become a challenge. In that case, a CT four vessel angiography or a DSA of the brain four vessels would actually be a test of choice. You could also do a cerebral perfusion scan, and you would also possibly have understanding with some other ancillary tests like EEG. Though EEG is very, very difficult to interpret and is not diagnostic, I think a cerebral perfusion scan and a four vessel DSA or a CT scan are pretty good. Now, as I said previously, Indian law does not allow us to use any of them to diagnose with the current status, but it's a process in evolution. Most of the other first world countries understand that if a clinical examination or apnea test is not possible for some reason, then we may use these tests. So these tests are not instead of brainstem death declaration. These tests are used only when a clinical declaration is not possible for some valid reason. However, I leave it at that. I don't want to discuss it any further. Now, just 2, 3 slides about donor maintenance. Now, what happens is when you are trying to save somebody's life, all your physiological support which you are giving before the brainstem death occurs is actually diverted towards maintaining the brain function, because that's the most important organ. So we try to maintain the blood pressure, we try to decrease the ICP, we try to minimize the seizures, we try to keep the glucose and the tonicity of the blood in a normal way. All of that is done. However, after the patient has had the first test done and the patient is now progressing on towards brain death, I think your focus should change from brain preservation, because it's not preserved anyway, it's dead, to actually organ preservations. And we can do that by using these donor maintenance guidelines. This is the paper which we wrote up, and we've just published the second edition of that as well. It is in the Indian Journal of Critical Care Medicine. It's a free paper available on text. It actually talks about managing a potential organ donor quite in detail, and all of you are more than happy to be referring to that paper. It has everything which you would need to do it. Quick rules which I try to sort of put up when I identify a donor. First is always measure a core temperature. I think majority of the people do not measure a core temperature, and they measure just skin temperature in the axilla or the tympanic membrane. And quite often you are having a patient who is hypothermic, who is not recognized. And 70 to 80% of the patients who become hemodynamically unstable are profoundly hypothermic. So it's better to avoid hypothermia. After the first test, if it is consistent with brain death, please stop mannitol and phenytoin, because all of these are just going to decrease your plasma volume and cause more arrhythmias and cause more problems. I think the rule of 100 works best. keep the blood pressure on 100 systolic, urine output on 100 millimeters of mercury, temperature as close to 100 degrees Fahrenheit, which is 98.7 if possible. Every 100 minutes, assess volume. Every 100 minutes, check for sodium. Keep your saturation as close to 100 as possible. I think the rule of 100 really works very, very well. And you could start vasopressin early if you have any signs of large output, large urine outputs, or even if the blood pressure goes down a little bit. I think with these, I would like to stop. If there is any question, I'd be happy to take. Thank you very much for the opportunity.
So we have a question for you. Why is the death certificate needed at the time of the second examination and not the first?
So, as per our law, the law is very clear that we have to do two tests at least 6 hours apart, and the time of death is the end of second apnea test when the PCO2 goes up. What I mean to say is that we are declaring a patient dead. I don't necessarily want you to write a death certificate, but in the notes, when you fill up a form 10, and I document in the notes that the patient is declared dead by brainstem death criteria at so and so time on so and so date. And then, of course, we fill up the death certificate when the body is handed over to the patient, but the time of death is put at the time when the second apnea test ended. That is the most important thing. If you are declaring a patient by brainstem death criteria, the time of the death is the second end of second apnea test.
Thank you, sir. And sir,
Hello.
so I
Sorry.
have a pediatric age group also.
So pediatric age group also, the again the law does not specify any targets on pediatric age group. Uh, the rule of thumb again is that for neonates and for children where the frontanels are not closed, you can actually have your timelines increase between the two tests. So you could go up to 24 or 48 hours. For patients, for 4 members of the committee, they can decide their timelines and they can come up to a agreed timeline session for a pediatric age group. For anybody above 1 year of age, I think you have to have essentially the same criteria which has been put up. There's absolutely no problem with that. Below 1 year is the concern.
So we have another question from Dr. Vivek.
Hi, Dr. Kute.
Yes, sir. Sir, in case of neonates, sir,
Hmm.
what should be the time duration between the two apnea tests? They mentioned that it should be long, but is there any cutoff like instead of 6 hour?
So usually, sir, we would go 24 or 48 hours. This is for the 4 members of the committee who are doing the brainstem death declaration for them to decide. I would say the longer you wait, the better it is. There is no cutoff time. The couple of times I have been requested to sort of look into that. We have waited for 48 hours. Uh, I don't have a lot of experience with pediatrics and neonate. I would not be the right person to talk about it in greater detail. But I think a 48 hours is more than enough to wait for a pediatric declaration between the two apnea tests, between the two tests.
Yes. Thank you, sir.
Sir, I have one question.
Mhm.
Sir, is our law allow us to do the apnea test in front of patient company, sir?
Sorry, doctor. Sorry, Shwetaji, can you just speak again, please?
Sir, is our law allow us to do the apnea test in front of patient company, sir?
Look, I think law has absolutely no objection of having a patient's family member in front of you. Wouldn't you declare a patient dead by circulatory criteria in front of the family member? Similarly, you could do a test in front of the family member as well. In fact, it's a more transparent way of doing it. I think we all interpret the law in a very, very scrutinized way and get worried about it. And my thought process on the ancillary testing is also the same. I think just because law doesn't say, the science doesn't end there. So ancillary tests are very much valid, but of course, everybody's opinion is important, and everybody's opinion has to culminate into a legal process which can come under the Noto banner. So I feel there is no rule which stops you from doing a declaration in front of the family members or in front of anybody in the hospital, provided the dignity of the patient is taken care of, provided you do it in a way which is keeping up with the humanity and the ethics of medicine. That's all.
Thank you, sir.
Thank you so much, sir. Your clarity in presenting the protocols of brain death declarations and donor management is commendable. Thank you
Thank
for
you.
guiding us through this critical and
Thank you.
often present. Thank you so much.
Thank
Next, we have with us a pioneer in complex transplants, Dr. Dipesh Nagar from PGIM Chandigarh. He brings us insights into donation after circulatory death, but growing but underutilized pathway in India. Dr. Nagar is Professor of Renal Transplant Surgery at Postgraduate Institute of Medical Education and Research in Chandigarh and a leading figure in kidney and pancreas transplantation in India. We welcome you to present your topic.
Am I audible?
Yes,
Yes,
sir.
audible, sir.
Thank you very much, Noto, for having me. I'll be presenting on donation after cardiac death and some considerations on how we can expand the donor pool by using this pathway of getting organs for donation. So I'm going to cover the importance of DCD, the types of DCD and how the basic outline of how DCD is done. What are the outcomes of DCD and the PGI experience that we've had, and what we might expect in the future with DCD, and what challenges we might expect in India if we try to uh, expand the DCD path for organ retrieval. So I don't think I need to go into this into a lot of detail because it's already been covered and repeated ad nauseum in so many transplant meetings that transplant is the gold standard for treating organ failure economically, medically, and quality of life outcomes, which greatly outweigh any other treatment option that you might look into. And the need for transplants is great as demand far outstrips supply, not just in India, but all over the world, even in countries which have fairly advanced transplant programs. I think maybe just a handful of countries which are actually able to have reasonable wait times waiting for a transplant. So just a handful of countries are actually able to fulfill their need for organs. If you look at the name category of donors, the types of donors that we have, so we've got live donors, and basically you're limited to kidneys and livers when you come to large organs, because donors need to live afterwards as much as the recipients. And the conundrum of transplant is you're giving a functioning organ to replace a failing organ. So obviously you need someone who doesn't need those organs anymore. And there is still a lot of debate on what kind of deal do the live donors get out of this when you're looking at young live donors who might have to live the rest of their life, maybe 30, 40, 50 years with a single kidney. And there's a lot of data that a nephron mass definitely affects your life afterwards. Like if you have a decrease in nephron mass, what happens to donors afterwards? So obviously, if you would need many organs, for example, pancreas, intestine, heart, lungs, and composite tissues like hand transplants or face, you're going to look at deceased donors, and we've got two types: that donation after brain death and donation after cardiac or circulatory death. So I'm going to refer to them as DVD and as DCD. Obviously, like I said, deceased donor organ transplantation is ideal. And for most of the world, donation after brain death is a major contributor for these organs. Why? It's because there's been a long and sustained interest in brain death as a diagnosis in itself. And that has resulted in, like what Pandit said, a quite a set process wherein you diagnose brain death. And because you might look at legislation and you might look at regulations as probably something difficult to fulfill, But these are also protected in the sense that once you have these regulations and you have these rules in place, you have a set process of saying this is somebody who is brain dead and we have fulfilled these criteria. It's very easy then uh, uh, to have a viewpoint that you stand on and say that these are the patients that we can actually ask for organs. Also, brain death donation overall is a much easier process than donation after cardiac death, uh, especially because you've got time as compared to donation after cardiac death, because the latter entails a rapid onset of organ ischemia. So if you have organ ischemia and you have to move really fast, which is logistically an issue. And if you want to counteract that, then you need a special setup as compared to uh, somewhere like you can diagnose a brain death donation in the ICU and have time to prepare your recipients. Historically, also, the reason why DCD is on the back foot is paradoxically the first deceased donor organ transplants were from DCD donors. And when these were tried early in the 20th century, transplantation itself was in a very nascent stage with very poor outcomes. We did not know much about tissue typing, about the immune response to transplantation, or even something so simple and fundamental now as the cooling of the organs. And by luck, by chance, fortune has favored DBD donation because about the same time when brain death certification processes were put in place is about the time when transplantation matured as a science and we had reasonably good outcomes, which made the DVD transplants the de facto method for diagnosing brain death, for diagnosing death for donors. If you look at DCD, then potentially lethal ischemia is the thing that you're looking to manage. It's a race against time when you're looking at DCD donation, whether you're doing control or uncontrolled. So if you have cessation of circulation, there is immediate onset of organ ischemia, organs die rapidly, and either you'll have to call off the transplantation, or else if you go ahead with such suboptimal outcome organs, then recipient outcomes are sometimes pretty bad, and you might sometimes think you're better off not doing. You might have been better off not doing such a transplant. Ischemia times wise, DCD donations tend to have the longest ischemia times, significantly more than live donors who have a somewhat a longer ischemia time as compared to DVD donors who basically have, uh, if you're done properly, basically you're going to look at a zero warm ischemia time. And warm ischemia time is where you lose a lot of the organ viability when you're doing these transplants. And roughly, I don't know whether there's any way to measure, but 15 minutes of cold ischemia time equals to 15 minutes to half an hour of cold ischemia time equals to 1 minute of warm ischemia time. So that's the kind of damage, ischemic damage that you're looking at. The classification of donation after cardiac death is actually based on the preparedness of the retrieval team to counteract the ischemia of circulatory arrest. So there's a mass spec classification of donation after cardiac death, which was initially had classes 1 to 4. So class 1 and class 2 are uncontrolled DCDs because you have no idea of what has happened before and even during the retrieval. So class 1 is dead on arrival to the emergency services, and class 2 is patient has come to the emergency services, had a cardiac arrest in the emergency services, and then was not able to be resuscitated. Class 3 is controlled DCT that we will look into just shortly. So this is an orderly withdrawal of life support with a ready retrieval team. And this is the kind of DCT that you're looking at if you want to get good organs. Class 4 is a cardiac arrest in a patient who's already in brain death, whether you've diagnosed before or during the, already diagnosed or during the diagnosis of brain death. And depending upon your setup, you can have varying degrees of control. So in some cases, you might have reasonably good control of your ischemia timeline, and sometimes it can be totally uncontrolled. And class 5 is an unexpected cardiac arrest in the hospital, and this is also mostly uncontrolled. So class 5 was added later on because some uh, programs were able to carry this out. So how is controlled DCD done? And paradoxically, for DCD, the first prerequisite is a non-survivable massive brain injury, not to the level of brain death. And you have continued pulmonary and circulatory functions which are dependent upon medical intervention to continue. And these are likely to stop if these interventions are withdrawn. So once the family has to agree with the treating unit on the futility of continuing medical treatment in such cases, they agree for withdrawal of life support, and counseling and communication with the family is uh, essential if you want to go ahead this way. Uh, this is most often carried out in or in close proximity to the OR to have to shift a donor using an elevator or a lift and long hospital corridors to reach the OR. Often you will have poor outcomes in DCD. Once in or near the OR, then you have monitoring of respiratory, circulatory, and oxygen status while life support such as ventilators and inotropes are withdrawn. And then over a period of time, circulation and oxygenation will decline and end in asystole after a variable period. So this period is the agonal period. So during this time, organs can sustain ischemia if your saturation. So you might have some degree of cardiac activity going on. You might have a pulse palpable, but if you have a saturation less than 70% or your mean arterial pressure less than 50 millimeters mercury, you'll have to take a call whether you're going to continue with the process or not, because this is your functional warm ischemia. So you have some degree of cardiac activity, but not enough to sustain the metabolic needs of the organ. And typically, you'll find transplant teams, transplant programs accept maybe 30 minutes to 1 hour of functional warm ischemia time before the call of the effort. Also, sometimes you can have a pretty long period. You might have to wait a long period for asystole to happen. So often there'll be set time limits depending upon what protocol which country is following. So you might have up to 3 hours of uh, period in which you will wait for asystole to happen. If it does not, then you might have to call off. Most of them they'll call off the effort or the transplant effort. Uh, some programs will allow interventions to optimize organ retrieval, for example, placement of perfusion catheters or maybe heparinization. But there's been a lot of debate on this because people have tried ethically also on ethical grounds to ensure that the number of interventions which contribute or may potentially contribute to dying should be limited as much as possible. So that was controlled DCD. Uncontrolled DCDs are definitely more fraught with problems. First is obviously logistics. Most of the times these are far from the OR, and there's likelihood of significant ischemia prior to or during the retrieval in such circumstances during the transportation, and also because of the hurried nature of the retrieval. And because it is rushed, it may be traumatic to bystanders, even to the team which is participating in the retrieval. And though there are some centers, depending upon cultural milieu, where controlled DCD is not existent or well developed. So there are many ethical questions as to what level of intervention should be done when retrieving organs for an uncontrolled DCD. Do you perform chest compressions, or what degree of the CPR protocol will you undertake to perform or to maintain organ perfusion? And what happens if this results in return of spontaneous circulation? How long do you wait then afterwards? Depending upon, because DCD has been such a topic in which people might have such differing takes, there have been quite a difference in how DCD has been implemented worldwide. So it has been increasingly contributing to the deceased donor organ transplantation, and significant proportions, up to 30 to 40% of all donations in countries such as UK, Spain, Holland, Belgium, Russia, Australia, and the USA, up to 30 to 40% the organs come from donation after cardiac death. So approaches are different. Like I mentioned, controlled DCD is quite common in the UK, Australia, and USA. And uncontrolled DCD is somewhat more common in Spain and funds, depending upon how comfortable they are with withdrawal of life support as end-of-life care. In India, we are not legally allowed to withdraw life support, so controlled DCD is out of the question for now. So there has been some progress from the judicial side and some progress from professional bodies, for example, the critical care fraternity, on withdrawal of life support and advanced directives and do not resuscitate. And also, there's a desire to recognize and optimize end of life care. So, what are the outcomes of DCDs? Organs that have been utilized after DCD: kidneys and livers in the thousands, pancreas and lungs in the hundreds, and hearts less than 100 or so, less than 50 actually. But these are the organs which are commonly utilized after DCD. The DCDs have the potential to have much poorer outcomes as compared to DBD because, like I mentioned before, uh, ischemia is a much more inherent part of DCD as compared to DBD. On the other hand, this is offset by a stricter selection of criteria for donors and recipients as compared to DBD. And with this, worldwide, the results, published results, appear to be acceptable and comparable to DBD. So, what's the future of DBD? Because you've got good outcomes, and countries like UK, US, Australia, Spain are reporting that DCD is contributing more and more to uh, the deceased donor organ transplantation. Is obviously DCD is likely to increase because neuroprotective care is becoming better, and you have a, a a lower percentage of patients now progressing to brain death. Some brain death is now preventable. Whether they can completely come back is a different question. There's also been improvement in traffic accident fatalities, better traffic, self-driving cars, and better compliance with personal safety requirements when handling vehicles. And there's also awareness and acceptance of the futility of excessive medical intervention in critically ill patients. So this awareness coming not just among family members, but also in the medical critical care fraternity itself. And obviously, advanced directives are becoming more and more common of the level of intervention that people will accept to be done on them when they themselves are critically ill. There's also a host of evolutionary changes in the organ transplantation itself, especially with regard to organ procurement and preservation. New technologies or new ways of doing things, for example, regional hypothermia, normothermic machine perfusion, or hypothermic oxygenated perfusion, and viability assessment, vitrification of organs, which allow us to not only take organs which have had some degree of or variable degree of ischemia, but also to assess whether these organs are fit for transplantation or not. And this is a projection that has been done: is that less than 10% of patients with brain trauma will have an easily diagnosable brain death, and up to 25% of deaths now happen in ICUs. So up to 90% of this, so one out of every four patients approximately, you might have to take some decision to have a limitation of what is the level of care that you'll be giving, whether you'll be able to bring them back to life as it is. So what's been our experience with DCD? So our first patient with DCD was in 2011, when we had a lady with interstitial lung disease, and she had a cardiac arrest in the ICU, was shifted to the OT, and we had a warm ischemia of 70 minutes. So like I said, logistics is a big part of DCD. So one kidney never functioned, and the second had a suboptimal function, lasted for just about I think maybe 3 years or so. 2014, we had to declare graft loss for the second recipient. So that experience led us to realize that it's not possible to keep organs within this limit of 60 minutes of warm ischemia, and we have to have some degree of organ preservation, organ perfusion during this period. And we decided then that we'll be continuing external cardiac massage in those patients. And we had considered prior cannulation for regional perfusion, but then we defaulted to using what we call the DBTL, the double balloon, triple lumen catheters, or else when that was not available, to go for a rapid cannulation when retrieving these organs. Over the next few years, we had refinement of our experience, and this is one example that where we had much better outcomes than what we started with. So a 22-year-old for a potentially brain dead donor family considered for organ donation could not be declared brain dead because sodium remained high at 180, 170. And in those days, I think 2013, 2014, when we were starting our program, our intensivists required some time to get up to speed with how to manage a brain dead donor. So nowadays it's much easier, but in those days it was difficult. And this donor had a cardiac arrest. Our recipients were already ready. So after cardiac arrest, the team decided, the ICU team advised us that they'll be continuing external cardiac massage for a total of 65 minutes, a total warm ischemia of 80 minutes. And then one of our two recipients then backed out saying that they were not willing for this transplantation. The one recipient who went ahead with the transplant with a single kidney after 5 years had a creatinine of 1.03. So that's a reasonably good outcome that you can stand up and say, yeah, this is a good outcome that we've had from DC. So between 2011 and 2018, we had 14 donors uh, where we had kidneys retrieved after cardiac arrest. So 6 patients of them were refused brain death certification because of high sodium or issues with achieving high enough PCO2 during apnea testing. 4 had cardiac arrest after first evaluation by brain death by the committee. 3 had cardiac arrest after brain death was certified. And the last patient is the patient that I had presented being our first patient in 2011. External cardiac massage was used in all donors except the first 2 or 3. So this was done manually in 3 patients, in 3 donors, and we had an automatic external cardiac massage machine applied to 8 of them. So the time for external cardiac massage was between 20 to 30, 20 to 40 minutes, and a total warm ischemia time ranging from 50 to 90 minutes. Only one patient, like I said, we considered bedside cannulation, so with a double balloon, and that was done for one donor. For 5 of them donors, we prefer to do an intra-op double balloon triple lumen catheter insertion. So these are the outcomes that we had. So we had 24 recipients out of 14 donors. The mean age of the recipients was 42 years. The mean age of the donors was 32 years. And we had pretty good output on day one in some of these patients, but all of them have had a really good serum creatinine, mainly because we were strict in our selection. So recent experiences again from 2018 to 2024, we had no DCD donations. And our recent experience again in 2025, just this year, we had one pancreas kidney DCD who the donor had cardiac arrest while they were preparing to retrieve organs from a DBD. So this patient now has stable graft function off insulin, euglycemic on oral hypoglycemic agents, so low dose oral hypoglycemic agents. The serum creatinine of 1.3 at 3 months post transplant, and 2 kidneys we got from a patient who had a cardiac arrest while preparing for brain death certificate. This donor had cardiac arrest 3 times, was resuscitated 2 of those times, and the third time could not be resuscitated, was taken up for retrieval. Rapid cannulation was done. The first patient was discharged on post of the 21, and the second patient was discharged on post of the 44. That's a 2 hours difference in cold ischemia time, and you had prolonged DGF in the second patient. So I think this highlights what the degree of ischemic damage that these organs can have. But both of these patients are having a serum creatinine of less than 1.1 at 2 months post transplantation. So there have been other centers who have published their experience. IKDRC Gujarat, Dr. Vivek Pute Center have published between January 1999 and January 2012. So they've also had a significant number of DCD, and these are the outcomes of with a 10-year survival of 67%, which is pretty good. DGF they observed in 36, and this is similar to the figures that we had. So is there a PGI model for DCD organ retrievals? And maybe, and I say maybe because we are used to this kind of retrieval, and whether that is a widely adoptable model is something which centers have to decide on their own, whether they're able to put in the kind of resources and the logistics that are required to develop an uncontrolled DCD program. So the PGI experience, people often ask us how we do our DCD, and we are at pains to point out that this is a target of opportunity. The external cardiac massage that we do is in response to the exigencies of the situation, that is to maintain organ perfusion while the OT was being made available. And this is not CPR. We're not working to resuscitate donor. We readily acknowledge that we have a set of unique local factors which allows UDCD to be done, uncontrolled DCD to be done. And that is, as a team, we're dedicated to transplant only, and we have a long-established DBD transplant program. Like I said, all our DCDs are a byproduct of a DBD which failed to mature. So we used and we expect to use only kidneys for now. We have not gone to other organs like the liver, and we might explore the pancreas sometime, but in the future. But we are for now only kidneys. We are very selective in which donors we felt could undergo UDCD, the uncontrolled DCD. The donor mean age of just 32 years points out that we the strictness of our selection for the donors. The same thing for the recipients. We look for recipients who will be able to sustain a significantly prolonged period of DGF. We've had very supportive administration, especially our coordinators and the hospital administration. Police also in and around our center are very sensitized to deceased organ donation. So, like I mentioned, from between 2020 to from sorry 2018 to 2024, actually, we've had no more uncontrolled DCD donations because our ICU became that proficient in maintaining the brain dead donors. So you will have, if you have good ICUs, the number of DCDs should actually be relatively low if you're looking at uncontrolled DCDs. If you have a really good ICU, you must be you would expect to be in a setup going for a control rather than an uncontrolled DCD like we had. So conjectures on DCD in India. Look, what can we surmise about the DCD donation situation in India? People are working hard for it. There have been position papers put out both by transplant teams as well as by transplant professionals as well as professionals in the ICU, the critical care side of things. And we would like Mastic 3 to be the standard, but I think none of them actually were. Till now, the legal framework has made withdrawal of life support treatment quite cumbersome. And we believe, as a transplant professional, I believe that DCD should be a side effect of good end of life care and of withdrawal of life support. So Mastiff 4 and Mastiff 5 is usually chaotic. They're in the gray zone between controlled and uncontrolled DCD, and you might miss out some organs. But these are relatively low-hanging fruit for established TB teams. If you have an established TB program, you expect that your transplant team is well versed with relatively rapid retrievals, and you have some of these patients who do go into cardiac arrest. Sometimes you'll get a warning that this patient has had maybe one or two prior arrests, have been resuscitated, and then will at one time go for an uncontrolled DCD. I think Mastic 3 is a much simpler and better way to do things. It is unambiguous, well organized, well defined. Time points are there for the ischemic damage it will accept. And it is established in the West. There's a large body of literature that supports it. So there are a lot of challenges in India, but the most important thing, it seems to be inertia now. I might go on and say what are the challenges of uncontrolled DCD. Like I said, logistics is difficult. Ischemia times difficult to cut short, and often retrieval teams need to be very well versed with what they're doing, and you might have to have them on for long standby, waiting for sometimes an uncontrolled DCD to happen, and you're constrained to use an in-hospital donor organ. The challenges for controlled DCD really seems to be one is that there is no end of life care in India practice as such. Lama is so commonly practiced in India, and I feel the main thing which stops us from going to controlled DCD is the inertia, both in terms of what we expect the legal aspects to be, and what we find in the medical community, the reluctance of physicians to offer families end of life options to say that, yes, this is how much we've done, no more is possible. Would you consider taking off futile medical interventions? This is my last message is that DCD transplant, if we did at PGI, I think anyone can do it. We are not a very special team in terms of ability, or what has helped us is that our team leaders have been very proactive and willing to do. sometimes difficult things also. Thank you. Thank you very much for your patient listening and for the opportunity presented by Noto.
Thank you so much, sir. Your explanation of the donation after supplementary deaths falls under experience and senior institutes of the country, eliminated a lesson known but a powerful opportunity to widen. So we thank you for your insightful. Lastly, we'll hear from Dr. Vivek Kutte on the topic of One Nation, One Stop Transplant Program to achieve self-sufficiency, the challenges and solutions. Dr. Kutte is professor in Unit of Nephrology and Transplantation at IKDRC in Hyderabad. With over 150 peer publications, his work has significantly advanced kidney transplantation in India, particularly in the areas of deceased donor programs and kidney pair donation. He is treasurer of the Indian Society of Organ Transplantation, former secretary of the Indian Society of Organ Transplantation, treasurer of the Transplantation Society, counselor of the Asian Society of Transplantation, and member of the Apex Technical Companies at Noto Locus. He is also ranked number one expert in kidney transplantation in India as per the experts in experts team rankings. So we welcome you, sir, to give your presentation.
Am I audible, madam?
So you are audible.
Yes, sir, audible.
Thank you, madam, for the kind introduction. And I have no words to express my gratitude to Dr. Anil Kumar, sir, and Noto family for giving me this opportunity to interact with you on One Nation, One Swab Transplant program for achieving self-sufficiency, challenges, and solution. As per GODT registry, less than 10% of patients with end-stage organ failure have access to the organ transplantation. With the leadership of Noto, India is number 3 in the world for absolute number of organ transplantation and number 1 in the world for living donor organ transplantation. 85% transplants in India are from living donation and around 15% are from deceased donation, which is active mainly in the South and West India. Over the last 10 to 15 years, the deceased donation rate per million population in India is less than 1. And to achieve self-sufficiency with deceased donation, the required rate is 64 per million population because the estimated need for kidney transplant is around 1.5 to 2 lakhs. So India is number 1 for living donor transplant and number 68 for deceased donor organ transplantation. These two modalities complement each other to increase access to the organ transplantation. 1/3 of the living donors, they are rejected because of either ABO or HLA incompatibility. These donors can be easily transplanted with swab transplant or ABO incompatible transplant. Around 80% of kidney transplant services in India are in private sector where cost is prohibitive for a common man and cost of ABO incompatible transplant is twice as expensive as compared to the ABO compatible transplant with added complications because of infections. So this is our largest registry of ABO incompatible transplant from 25 centers, and 1759 ABO incompatible transplants were compared with 33,000 ABO compatible transplants. The main problem were cost and infections. So the legal and cost effective solution for incompatible patient in Indian scenario is a swap transplant, where two incompatible pair exchange kidney with each other to receive the compatible ABO compatible transplant. This is our single center experience of kidney swap transplant. Data from 2000 to 2024, 539 kidney swap transplants were included in this single center analysis, and this is the largest single center study published in the Asia. Graft survival, patient survival, acute rejection rate, graft function is similar to any ABO compatible transplant. And if our success is replicated in other centers in India, this will increase living donor kidney transplant by 25%. In our center, so far, we have done more than 600 kidney swap transplants. 75% are two-way exchange. But to increase access to difficult to match patients, we have also done a long cycle like 3-way, 4-way, 5-way, 6-way, 7-way, and even 10-way cycles. That is 10 patients and 10 donors were transplanted with the swap transplant. Basically, more surgical team is needed to carry out simultaneous surgery in the long cycle. This is our recent publication in a prestigious Lancet Asia journal, nationwide retrospective cohort study, 2 decades of kidney and liver swap transplant in India. 1839 kidney swap from 65 centers and 259 liver swap from 7 centers were included in this retrospective analysis. Around 90% of kidney and liver swaps are two-way exchange. Due to lack of software, we usually perform the two-way exchange, and more surgical team is needed to carry out simultaneous surgery if we perform long cycle like two-way, three-way, and long cycles. So lack of software and surgical team limitations are the reasons for performing short cycles in India. This is the largest registry of kidney and liver swap published in the world literature from 72 centers. It concludes that swap transplants are medically simple but logistically complex. Access to kidney and liver swap was unequally distributed and likely underused in our cohort. The left panel is showing India map of living donor kidney transplant, and right panel is showing India map of living donor kidney transplant with swap. Gujarat is number 1 state in India performing maximum number of swap transplant. Like in our single center, we have performed more than 600 swap transplants. Then Maharashtra, Rajasthan, Delhi, and Kerala. These are the top 5 states for swap kidney transplant in India. So what is need of one nation, one swap transplant program? Our single center experience has shown that living donor kidney transplant can be increased by 25% despite a single center program. If we start the national program or multi-center program, this will increase living donor kidney transplant by 25 to 35%. So, for example, around 12,000 living donor kidney transplants are performed in India with the help of national swap transplant. Additional 3,000 to 3,500 swap transplants will be generated. So, when these patients will be also reduced from the deceased donor waiting list, that is another major advantage of national swap transplant program. then less surgical team is needed for simultaneous surgery to avoid donor renage. That is one of the biggest advantage of multi-center program and national swab transplant program. So based on our experience and publication in Lancet Asia, I will briefly discuss challenges and solution for national swab transplant program under the headings of legal permission, registration, allocation, undertaking multicentric swab, and addressing the patient's concern. Legal permission for multicentric swab. It is legally permissible under Organ Act provided that it receives necessary approval from authorization committee, follows ethical practice, and ensure informed consent from both donor and recipient. It should be explicitly addressed so as to avoid any hesitancy and different interpretation of the act in relation to the swab. Which donor-recipient relationship is permissible in swab? Currently, only near relatives, that is parents, spouse, sibling, grandparents, as defined under Organ Act, are legally permitted to participate in swab transplant. The act may need to be relooked and modified, not to restrict only to near relatives in swab, to optimize matching like in any other living donor kidney transplant. This is done in the state of Kerala. Then is interstate matching is permissible? Yes. Our Lancet Asia paper shows that almost 50% pairs are from interstate matching. So interstate swap is legally permissible under THOA and should be encouraged to expand matching opportunity. It should be explicitly permitted under Organ Act and broader guidelines should be included under rules. Then who should give permission for multicentric swap? On page number 42 of Transplant Human Organ Act 2014, it is mentioned that authorization committee of hospital or district or state in which transplantation is proposed to be done should give permission for multicentric swab. This approach ensures consistency, transparency, proper oversight while ensuring compliance with the Organ Act. Documents required for the multicentric swab. I would like to acknowledge the letter from Dr. Anil Kumar sir about the checklist required for the swab transplant as per the Organ Act, and before accepting any confirmatory match offer for pairs, all center must ensure that documents in accordance with the NOTO checklist under Organ Act are completed, checked and uploaded. Legal process may be expedited with online document submission, Aadhaar-enabled biometric clearance system, and video interview of the pairs. The authorization process should be completed within 7 days, and any delay must be explained as per suggested by the DGHS letter. Where the pair should register for the swab transplant. A centralized national online swab registry portal by NOTO should be established where all pairs are mandatorily registered and information and data can be assessed as per legal and eligibility framework. What should be the ideal timing of swab counseling with the pairs? Swab should be introduced at first counseling session for eligible pairs, ensuring that all patients registering for deceased donor kidney transplant are offered counseling about all available alternatives of renal replacement therapy, including swab transplantation. We have noticed that 90% of the patients who are registered on the deceased donor waiting list, they are not available. They are not aware about the alternative options. Many times they have incompatible donor, but they are not explained about this option. So I will request Anil Kumar sir that a letter may be issued mentioning that awareness about all options of renal replacement therapy, including swab transplant, should be made mandatory for all patients who is getting registered for deceased donor kidney transplantation, so that patient can take informed decision considering into account pros and cons of available options as per the resource settings. Then donor participation in the swap. Donor must be medically fit, mentally competent, free of pressure and financial gain, and undergo psychological evaluation. Clear documentation and joint case review between centers are crucial for ensuring transparency and safety. Then whether complex living kidney donor can participate in swap. This is very common because we have limited donor pool. Many times the parents and spouse are having hypertension, they are on single drugs, and comorbid condition is well controlled. So recipient willing to accept complex living kidney donor should be clearly documented and recorded in the swap registry to ensure transparency and support informed decision making. As far as possible, organ of similar quality should be exchanged. That is, complex living kidney donor can be matched with complex living kidney donor to maintain fairness and clinical balance within the program. Then, can multiple donor do registration for one recipient? Yes. Multiple healthy willing donor may be registered specially for difficult to match pairs, but will be linked with the same recipient to improve the matching chances and reduce the waiting time. Final donor selection should be based on clinical and immunological suitability once a match is identified. Then donor recipient HLA and age mismatch pair, that is compatible pair enrollment. Inclusion of such pair in swap, if done, must be voluntary and fully informed consent must be obtained. Pairs must understand that participation may not guarantee access to a better donor because this depends on the donor pool. Any benefit conferred to such pair must be transparently documented, that is, improve HLA match, young donor age, or lower risk profile as per living donor KDPI calculator, and justifiable based on medical need or program utility. Their participation must be time bound, and a clear timeline should be discussed at registration to ensure unnecessary delay in the transplant. Variation in donor and recipient fitness criteria in different centers. All centers participating in multicentric swap should adhere to uniform evidence-based eligibility criteria for assessing donor and recipient fitness. Transparent documentation and joint review mechanism should be established for complex or borderline cases to ensure consistency and clinical accountability. Frequency of donor and recipient fitness assessment after registration. Fitness for both donor and recipient should be regularly assessed. Updated transplant team clearance with designated time frame must be obtained before accepting the final allocation matching offer for swap pair and prior to seeking legal approval for transplant under Organ Act. Then immunological workup. We suggest a robust immunological evaluation to prevent unequal outcome because of immune injury. It should include ABO typing, HLA typing of both donor and recipient, preferably high resolution, and HLA antibody detection in sensitized patients using standardized method at accredited labs. All test results must be digitally recorded and standardized across participating center, available to the central registry for real-time match run simulation and accompanied by declaration of unacceptable antigen in sensitized patients. So robust immunological assessment prevent unequal outcome because of immune injury. Then enrollment of the pair. We recommend that Noto establish one window clearance system for registration, allocation, and facilitating legal permission, even though health is a state matter. Because swab transplant is basically logistically complex, no extra services are required other than any living donor kidney transplant program. Then information to be documented at registration. All medical details of recipient and donor transplant center should be entered in a centralized online database of Noto. All legal documents and medical reports must be submitted, and informed consent for data sharing should be taken from both donor and recipients to ensure smooth coordination between centers. Then how long pair should wait for getting swab transplant? A large swab pool minimizes time required for getting the pair in the swab. So expected waiting time should be clearly communicated at swab registration, and pair should regularly update it. Additionally, yearly counseling should be provided to explain all available options, including ABO incompatible transplant and desensitization protocol, so that all modalities can be complemented to increase access to the kidney transplantation to individual patient as per available resources. Pair matching in multicentric swab. A centralized, standardized swab matching platform should be adapted, accessible to all authorized center, and integrated with registry. Access to swab should not be denied in absence of single window registration allocation, particularly in the resource limited setting. So far in our center, we have used a software provided by Alliance for Pair Donation, but recently Indian Society of Organ Transplantation has also made the software, which we have demonstrated to the Noto, so that a best possible way can be find out for starting the most user-friendly software in the national program. Optimal frequency of match run. It should be 4 to 6 weeks, balancing clinical urgency, logistical capacity, and registry size. There should be flexibility to allow ad hoc run in exceptional cases or special requests from the pairs, particularly for sensitized and urgent recipients. What is acceptable match pair? An acceptable match pair should be identified through a validated matching process in which donors meet recipients' medical, immunological, logistical criteria, and both transplant center confirm clinical suitability and willingness to proceed. A uniform definition of accepted match pair should be adopted in the national program. Then, what is the importance of donor recipient age mismatch? Donor recipient age mismatch should be minimized when possible, particularly for the young recipients, to maximize graft survival and long-term benefit. While not an exclusion criteria, age difference more than 20 years should trigger additional clinical review and shared decision making between transplant team and patients. However, it should not be limiting factor for hard to match patients because donor age between 18 to 65 year does not matter for outcome of living donor kidney transplant. Then what is impact of donor age difference? Efforts should be made to match donor age of each pair as closely as possible. For hard to match pairs, pair with longer waiting time, donor age matching should not be given much importance and pair should be counseled accordingly at the time of registration because we also need to consider morbidity and mortality on long-term dialysis program. Then non-immunological donor characteristics, transparent sharing of relevant non-immunological donor information through counseling of peers should be ensured to support informed decision making and maintain trust between peers. Then which should be promoted, multi-center or single center swap? National and regional transplant authorities should actively support and prioritize development and governance of multi-center and national swap over single center program because the quality and quantity of matching will be better in the national program. These include establishing interoperable registry, standardizing clinical protocol, investing in match algorithm, data infrastructure, coordination mechanism to ensure equitable access and maximize transplant opportunity. Then what should be the way forward from single center to the national program? It should be started in a phased manner, starting from city, state, multi-state, and national program. This approach balance scale with operational readiness and ensure safe, equitable, and efficient transplant delivery across geography. Then what should be preferred? Short cycle versus long cycle in the multi-center swap. Initially, limit exchange to the two-way and three-way cycle because logistics are very simple in the short cycle. Long cycles may be considered for hard to match patients as infrastructure, coordination, and experience improve. Physical cross-match in multicentric swap. The decision to conduct specific tests should be based on individual clinical circumstance. The physical cross-match, if undertaken, should be carried out at the transplant center where surgery will take place and follow standardized protocol. What should be promoted? Non-anonymous allocation versus anonymous allocation. Non-anonymous allocation means patients, donors, they are allowed to meet each other. They can exchange medical reports with each other. So non-anonymous allocation should be encouraged where culturally and ethically appropriate as it can foster trust, transparency, sense of shared altruism among participating donor and recipient pairs. Autonomy, privacy, preferences of all donor and recipient must be fully respected. Participation in non-anonymous arrangement should remain entirely voluntary and no individual should be pressurized into identity disclosure. But so far, all centers in India are doing only non-anonymous allocation. That is, they can share medical reports with each other and they can meet with each other before, during, and after transplant. Transparency for decision and for donors and recipient. SWAP program should provide clear, consistent, standardized information to both donors and recipients at every stage of SWAP process, including details of matching procedure, medical, logistical consideration, potential risk, available options, legal and ethical implications. All communication should be delivered in a culturally sensitive, understandable format, respecting each participant's autonomy, literacy, and emotional need. Then, what should be preferred? Donor travel versus kidney transport. So far, in India, more than 100 cases of multicentric swap is done, and all have preferred donor travel. So participating transplant team should carefully assess most appropriate mode of exchange, donor travel versus kidney transport, on case by case basis, and decision of donor and recipient should be final. Donor travel is generally preferred as per Indian evidence. However, kidney transport may be considered for public-private hospital swap with consent of payers. Donor travel possesses a significant personal, medical, and legal burden. Surgical or transplant capacity is centralized in one center. Institutional or recipient-specific factor make organ shipment more appropriate. All decisions must be documented transparently, supported by informed consent, and guided by national regulations and best clinical practice. Noto Transport SOP for multicentric swap. Noto Transport SOP for organ transplant should be integrated with the National SWAP program also to ensure operational readiness, equity of access, and clinical viability in SWAP across diverse geographical area of the India. Then simultaneous versus sequential surgery. The gold standard is the simultaneous surgery. Donor nephrectomy must be performed simultaneously to prevent donor renage, while corresponding recipient surgery can be conducted simultaneously or sequentially. Sequential surgery should be undertaken in a carefully selected pairs by a team with prior experience to minimize donor renage. All efforts should be done to minimize surgical interval and ensure recipients are transplanted before their donors give their kidney. Every precaution should be taken to avoid risk of donor renage. Then unequal outcome for payers. Transplant team should focus on clear counseling and informed consent, follow standardized transplant protocol for evaluation, comprehensive immunological assessment. The possibility of unpredictable complication and rejection up to 5 to 10% is possible despite all efforts. And this unequal outcome is mainly due to comorbid conditions in the patient. We can prevent unequal outcome due to donor related factor, but we cannot prevent unequal outcome because of patient related factors like comorbid conditions. This should be appropriately counseled and documented before transplant. Consent in the swap. All donors and recipient must be fully informed about risk, benefit, logistics with written consent obtained from all pairs in the native language. Social, cultural, and religious differences. By respecting and addressing diverse social, cultural, and religious factors, the transplant team should ensure that process is more patient-centric and comfortable for every pair involved in the process. Strict policies against financial compensation should be followed as per Organ Act. Donor should undergo mandatory psychological evaluation to prevent coercion as mandated in Form 4 for fitness of living donor kidney transplant. Then how we can manage financial differences between the pairs, especially when we do swap between public and private hospital. Conducting swap between only public hospital or only private hospital. The solution is simple, but this reduces the donor pool and quality of matching. So this cannot be the ideal solution. Kidney transport instead of donor travel. This is more practical solution. This ensures that donor from public hospital do not incur higher cost of surgery. Kidney transport enable program to function across both public and private hospital while mitigating financial barrier. Extra cost of donor travel should be shared by all payers. Establishment of government fund to support any cost which is needed for donor travel or kidney transport. So, kidney travel over donor travel. Financial disparity between the payers in public and private hospitals should be addressed by prioritizing kidney travel. Noto transport SOP should be implemented for kidney travel, covering additional cost for donor travel if needed. This can be done with the help of government funds or common funds from all the participating transplant center. Then phase implementation and teamwork for national swab program. It should be implemented in a phase manner, starting from city-based program, state program, then successful city-based program and state program can be merged in the national program. Then gender-related concerns. Ensure equitable access, resource allocation and support for all gender. Additionally, counseling and educational material should be tailored to address unique challenges faced by women, including societal pressure, health concerns, and familiar responsibility. More female healthcare professionals and patient ambassadors should be involved in process to create more inclusive and supportive environment for woman and girl child, both as a recipient and donor. Then transplant coordinator should receive a specialized training to effectively counsel and support peers and function as a one-stop solution for all problem. It could be medical, legal, social and financial guidance. So swap is basically a logistic issue. A one-stop solution will help the patient to overcome this logistic problem. To summarize, legal, cost-effective national swab transplant program will increase living donor kidney transplant by 25 to 35%, and this will prevent commercial transplant. Ease of doing swab using Noto's One Nation One portal for registration, allocation, and expediting legal permission will overcome the logistic issue. One Nation, One Document checklist as issued by the Noto is very useful because all majority of the states have adapted the Organ Act and they should follow this document checklist as circulated by the Noto under the provision of Transplant Human Organ Act. User-friendly software for allocation. We can do more complex matching with the software. Incentives for promoting multicentric swap. I will request Dr. Anil Kumar sir for issuing one additional letter for mandatory counseling about available options for renal replacement therapy, including swab, for any patient who is getting registered for the deceased donor kidney transplant. With the help of this, we will increase transplant for incompatible pairs and also, most importantly, reduce waiting time for pairs who are already registered in the deceased donor waiting list. We can use online document submission, video interview of the pairs to expedite the legal permission. Donor first policy should be prioritized to decide over donor travel versus kidney transport. Living donor advocates and swap patient ambassadors will overcome the concerns of the patient. Organ Act reform is needed to permit other than near related donors in the swap, and reform is also needed to permit international swap from near related donors. Most importantly, government support matters to start the national swab transplant program. In year 2025, in 6 months at Kidney Institute Ahmedabad, we have performed 50 swab transplant and this has increased access to living donor kidney transplant by 25 to 30%. At the end of March, we have done another 10-way swab transplants, 10 patients and 10 donors. These prayers were from 7 different states of India, suggesting unity in diversity. Thank you for your attention.
Thank you so much, sir, for showing us today how intent and coordination can make miracles happen even across regions. The One Nation, One Swap program is not just a slogan, but it is a revolution in patient management. Thank you so much.
Thank you, madam.
Thank you, Professor Kutek. And definitely the SWAP program has a potential to not only increase the donation, but also to improve the outcomes of the transplant because the donors are well matched with the recipients. So outcomes are also likely to improve. So thank you so much. And so we don't have any questions. So I will request just a formal vote of thanks from Dr. Kanika Stogi to specialist Noto. She is a specialist in technology at Noto. So she'll be proposing a vote of thanks to everyone.
So before we conclude, I would like to express my heartfelt gratitude to the chairperson, Dr. Sunita Sharma, Director General of Health Services, for her invaluable support and guidance in making this national webinar a success. Her unwavering commitment to public health and towards advancing the cause of organ donation in India continues to inspire and empower professionals across the country. I extend my deepest gratitude to all the distinguished speakers who joined us today. Your expertise, insights, and passionate advocacy have made this session truly meaningful. I thank our director, sir, Dr. Anil Kumar, for his guidance and support all along. His dedication to the cause strengthens our collective response to transform lives, organ donation, and transplantation. I'm thankful to the entire team at Novo for their tireless efforts in making this webinar a grand success. And lastly, we sincerely thank all our audience for contributing to a session rich with knowledge and purpose. Let's carry today's learnings into tomorrow's practice, and let's ensure that no one waits in vain for an organ and no gift of life is ever wasted. Thank you.
James.